Imagine this. Your blood volume surges by almost half. Your heart starts beating faster, like you've just run a marathon, but you're just sitting there.
Hmm.
Now, picture this happening while your body is also working incredibly hard to grow a tiny human.
It's a huge undertaking physiologically.
And here's a twist. Sometimes the sheer effort of it all can actually, reveal a hidden weakness in your heart or even trigger a new condition you never knew existed.
That definitely happens. Pregnancy is like a stress test for the cardiovascular system.
It sounds like something out of a medical drama,
Right.
right? But this is the reality of pregnancy and its profound impact on the cardiovascular system.
It's a remarkable and often underappreciated aspect of pregnancy. The physiological changes a woman's body undergoes are just immense, and their interaction with the heart is a really critical area of understanding.
Absolutely. Today, we're diving deep into this fascinating and crucial relationship between pregnancy and heart disease.
Yeah, there's a lot to unpack.
We'll be exploring expert insights to understand exactly how pregnancy affects the heart, the potential risks for mothers, both with and without pre-existing conditions, and the latest advancements in care.
Which are constantly evolving.
So if you've ever been curious about this intricate connection, you've definitely come to the right place. We're going to break down the complexities and highlight what truly matters.
And understanding this is just so important because it touches the lives of so many people. It's not just about individual health. It really informs how we approach maternal care on a much broader scale.
Totally agree. Before we delve in, though, a special thank you to London Heartbeat Z Academy UK for their educational support.
Great resource.
They offer over 150 popular courses, and we highly encourage you to explore them. You can also follow them on Facebook, Instagram, and YouTube for free, regular updates and, to stay informed about future amazing discussions like this one.
Yeah, access to reliable information is just key. And resources like London Heartbeat Z Academy play a vital role in getting that crucial knowledge out there.
Okay, so our mission today is clear. To extract most vital knowledge concerning pregnancy's effects on the cardiovascular system,
Right.
the potential complications for women regardless of their prior heart health, and the continuously evolving strategies for providing care in this, well, pretty complex field.
It really is complex.
We've gathered a wealth of information and we're ready to unpack it for you. So let's start right at the beginning. What exactly happens to a woman's heart and circulation during a, normal pregnancy?
What's really striking is just how early these cardiovascular adjustments begin. The combined hemodynamic, meaning changes in blood flow and pressure and hormonal stresses of pregnancy start to manifest as early as the 6th week of gestation.
6 weeks. Wow, that's often before someone even realizes they're pregnant. So what are the specific changes that kick in so early?
Well, we see a significant increase in plasma volume, which is the liquid part of your blood.
Okay.
And simultaneously, there's a decrease in what's called peripheral vascular resistance. Think of your blood vessels basically relaxing and widening.
Okay, so the body is increasing the amount of fluid in the system while also making it easier for that fluid to flow. What effect does this have on blood pressure then?
Interestingly, this often leads to a small drop in blood pressure, typically about 5 to 10 millimeters of mercury below the woman's baseline.
Uh-huh.
And this lower blood pressure usually persists until the 3rd trimester.
A dip in blood pressure seems kind of counterintuitive when the body is clearly working harder.
That's right, it does seem that way. But the body compensates in other ways. For instance, the heart rate increases, usually by approximately 10 beats per minute.
Okay.
And maybe more significantly, the cardiac output, that's the total amount of blood the heart pumps out each minute, increases dramatically by about 30% to 50%.
Whoa, 30 to 50%? That's a massive increase in the heart's workload.
It is. It's a huge adaptation.
And what happens if a woman is expecting twins? Does the heart have to work even harder?
Absolutely. With twin pregnancies, the demands are even greater. The cardiac output can increase by another 10% to 15% on top of that already significant rise.
Wow. So pregnancy puts a tremendous strain on the heart starting very early on. Now what about the main event? Labor and delivery. I can only imagine the cardiovascular system goes into, overdrive then.
That's a very accurate way to put it. Labor and delivery represent a period of peak cardiovascular stress. During this time, cardiac output can surge by another 60% to 80% compared to pre-pregnancy levels.
60 to 80% more. That sounds incredibly risky. What triggers such dramatic spike?
Several factors come into play. There's a release of hormones called catecholamines, similar to what happens during intense stress or, excitement.
Okay, adrenaline rush, basically.
Sort of, yeah. Additionally, the compression of the inferior vena cava, that's a major vein returning blood to the heart, is relieved as the baby descends.
Right.
Uterine contractions lead to what we call autotransfusion, where blood from the uterus is kind of squeezed back into the general circulation.
Oh, I see.
And of course, there's also the impact of blood loss during delivery. It's a really complex interplay of physiological events happening all at once.
So it's almost a perfect storm of factors putting extra pressure on the heart. What are the immediate consequences after delivery? Is the stress over then?
Not quite. Actually, the first week postpartum is a particularly vulnerable time as the body starts to mobilize and redistribute all that extra fluid.
Okay.
Women with pre-existing conditions like cardiomyopathy, that's a weakening of the heart muscle, or severe outflow tract obstruction, a narrowing that restricts blood flow from the heart.
They're at increased risk of developing heart failure during that first week.
So even after delivery, the heart is still under significant stress as the body tries to, get back to its pre-pregnancy state.
Hmm.
How long does it typically take for these major cardiovascular changes to resolve?
Well, the good news is that many of these hemodynamic changes tend to resolve relatively quickly, usually within the first 2 weeks after delivery.
Around 2 weeks.
But it's important to remember that the increased risk doesn't just vanish instantly, which really underscores the necessity of careful postpartum monitoring, especially for higher risk women. That makes perfect sense. Pregnancy is clearly a major cardiovascular event, no question. Now, let's shift gears and talk about how doctors evaluate a woman's heart health, both before and during pregnancy. It seems like some of the normal symptoms of pregnancy could easily be mistaken for signs of a heart problem.
You've hit on a really crucial point there. The overlap between the normal physiological changes of pregnancy and the early signs of cardiac issues can be quite significant, making accurate evaluation absolutely essential.
Right. So what are some of the common symptoms that a pregnant woman might experience that could be due to either, just normal pregnancy or potentially a heart problem?
Symptoms like fatigue, shortness of breath, which we call dyspnea, lightheadedness,
Hmm.
and palpitations, the feeling of your heart racing or fluttering.
Yeah.
Those are all really common during pregnancy.
Hmm.
But they can also be indicators of underlying cardiac issues, so you can't just dismiss them.
Okay, so relying solely on symptoms isn't enough. What will a doctor look for during a physical examination to help differentiate between normal pregnancy and a potential heart problem?
A careful physical examination can provide valuable clues. In a normal pregnancy, a doctor might observe what we describe as collapsing arterial pulses. They feel more forceful and then disappear quickly.
Okay.
They might also see prominent jugular venous pulsations in the neck, though without an actual elevation of the jugular venous pressure, which is key.
Right.
The point where the heartbeat is felt most strongly on the chest, the apical impulse might be displaced slightly to the left.
Uh-huh.
In some cases, the right ventricle, or the pulmonary artery, might be palpable. And finally, a soft, short ejection systolic murmur that's a specific type of heart sound might be heard, typically in the pulmonic area or along the left sternal border.
Wow, those all sound like things that would definitely raise concern if you weren't pregnant. It's amazing that these can be normal findings.
Exactly. And this is why it takes a skilled clinician to differentiate these expected pregnancy-related findings from those that might indicate early cardiac decompensation, meaning the heart is starting to struggle. Often, further testing is necessary to get a clearer picture.
Okay, so if symptoms and the physical exam are ambiguous, what kind of tests are most helpful in distinguishing between these normal changes and actual heart problems during pregnancy?
Echocardiography, which is basically an ultrasound of the heart, is really a cornerstone of cardiac evaluation in pregnancy.
Right, ultrasound. Safe.
Exactly. But in addition to that, measuring the levels of a hormone called B-type natriuretic peptide, or BNP, in the blood can be very informative.
ENP. Okay, can you explain a little more about what that is and why it's helpful here?
Sure, BNP is a hormone released by the heart muscle itself when it's under stress or when there's increased pressure inside the heart chambers. So elevated levels of BNP can suggest that the heart is working harder than it should be and might indicate heart failure.
Okay, so a high BNP level could be a red flag. What's considered a significant level in a pregnant woman?
Well, a BNP level greater than 111 picograms per milliliter has been shown to have a positive likelihood ratio of about 2.5 for heart failure in pregnant women. But it's important to note that pregnant women who already have heart disease may have naturally higher BNP levels at baseline anyway.
Ah, so the interpretation needs to take the woman's pre-existing condition into account. What if the BNP level is low? Is that reassuring?
Yes, very much so. A BNP level below 100 picograms per milliliter in a pregnant woman who is known to have heart disease has a very high negative predictive value, almost 100% for significant cardiac complications.
Wow, 100%.
Yeah, basically, if the BNP is low, it's extremely unlikely she'll experience major heart issues related to her heart condition during her pregnancy.
That's really valuable information. So echocardiograms give us a picture of the heart's structure and function. BNP levels give us an indication of the stress it's under. What about other common cardiac tests like electrocardiograms, ECGs, and chest x-rays? What role do they play?
ECGs, which record the electrical activity of the heart, and chest x-rays can also show changes during a normal pregnancy that might, superficially resemble findings in heart disease.
Oh, great. More potential for confusion. What specific changes might we see on an ECG during a normal pregnancy that could look like something else?
An ECG might show a slightly faster heart rate, what we call sinus tachycardia.
Okay.
We might also see premature atrial or ventricular complexes. Those are extra heartbeats. There can be shifts in the electrical axis of the heart, sometimes showing a slight leftward deviation. Occasionally, small Q waves might appear in the inferior leads, and there could be a flattening of the T waves or even some ST segment depression. And finally, there might be an increased RS ratio in the right precordial leads, which kind of reflects the increased workload on the right side of the heart.
So even the electrical patterns of the heart can shift during a healthy pregnancy. What about chest x-rays? What changes might be seen there?
On a chest x-ray of a pregnant woman, you might observe a small amount of pleural effusion that's fluid around the lungs. The left upper border of the heart might appear straighter, and the heart itself might appear to be positioned more horizontally within the chest because the diaphragm is pushed up.
Right, makes sense.
Additionally, the blood vessels in the lungs might look more prominent due to the increased blood volume we talked about.
It really sounds like interpreting any of these tests in a pregnant woman requires a deep understanding of normal pregnancy physiology to avoid misdiagnosis.
Absolutely. And even echocardiographic findings, the ultrasound, can be different in pregnancy. We often see an increase in the dimensions of all four chambers of the heart.
All four? Wow.
Yes, though the left ventricular ejection fraction, that's a measure of how effectively the main pumping chamber is working, usually stays within the normal range.
Okay, so function is preserved.
Usually, yes. The wall thickness of the left ventricle might also increase slightly. It's also quite common to see an increasing degree of tricuspid regurgitation, where the valve between the right atrium and right ventricle doesn't close perfectly, although this usually doesn't exceed a moderate level. Furthermore, there can be subtle changes in the mechanics of the left ventricle, things like strain, twist, and untwisting patterns, as well as adaptive changes in the left atrium. And interestingly, the left ventricular diastolic dimension, the size of the chamber, when it's relaxed and filling, may even exceed the normal limits typically reported in non-pregnant individuals.
It's just fascinating how much the heart remodels itself structurally and functionally during pregnancy. Now, when cardiac testing is deemed necessary, what are the key considerations regarding safety for both the mother and the baby? That's obviously paramount.
Safety is always the top priority, absolutely. When considering any medical intervention during pregnancy, especially cardiac testing, we need to weigh the benefits of getting crucial diagnostic information against any potential risks, particularly radiation exposure.
Let's start with the preferred imaging method you mentioned earlier, the transthoracic echocardiogram, the regular heart ultrasound. Why is that the go-to?
Transthoracic echo is preferred because it uses ultrasound waves, not ionizing radiation, to create images of the heart. It's safe and readily available.
Okay.
However, as we discussed, the physiological changes of pregnancy, like the enlarged uterus pushing the heart upwards and to the left, can sometimes make it technically more challenging to get really optimal images.
Gotcha. What if the transthoracic echo just doesn't provide enough information? Are there other imaging options?
Yes. Transesophageal echocardiography, or TE, is an option when we need a clearer view of certain structures.
Right.
For that, the ultrasound probe is placed in the esophagus, much closer to the heart.
Right.
But during pregnancy, we typically use an abbreviated protocol for T to minimize the risk of aspiration because pregnancy can slow down gastric emptying.
That makes sense, a safety precaution. What about exercise stress testing? Is that ever used during pregnancy?
If exercise testing is deemed necessary, it should really be limited to submaximal levels. We usually aim for a peak heart rate of around 70% to 80% of the predicted maximum for the patient's age.
Submaximal only?
Yes, and we generally avoid using pharmacological stress agents, like dobutamine, during pregnancy. Ideally, exercise testing is done before pregnancy if needed.
Okay, now let's address the big concern. Radiation exposure from cardiac imaging. What are the general guidelines? How much is too much?
The greatest concern regarding radiation exposure is definitely during the first trimester, as this is when the baby's organs are developing organogenesis.
Right, the critical window.
But it's reassuring to know that a cumulative fetal radiation dose of less than 50 milligray is generally considered to have a negligible risk of fetal harm.
Okay, 50 milligray is the sort of threshold we're thinking about. What about specific imaging modalities? How much radiation do they typically involve for the fetus?
A standard chest X-ray involves a very, very low fetal radiation dose, typically less than 0.00001 milligray. And it's crucial to use maternal shielding, like a lead apron over the abdomen, during the procedure to further minimize any potential exposure.
Tiny dose plus shielding. Got it.
Lung ultrasound is actually an excellent alternative for evaluating things like pulmonary edema or other lung pathology, as it involves no radiation at all.
Good point. Ultrasound again.
If a chest CT scan is absolutely necessary, for example, to diagnose a pulmonary embolism or maybe an aortic dissection, then low radiation dose protocol should always be employed. A typical CT pulmonary angiogram using these protocols delivers a fetal dose in the range of roughly 0.01 to 0.66 milligray.
Still well below that 50 milligray threshold.
That's generally yes. Cardiac magnetic resonance imaging, or MRI, is another valuable alternative to techniques that use ionizing radiation.
Okay.
However, the use of gadolinium-based contrast agents should be avoided if possible during pregnancy, and the longer scan times for MRI might make it less well tolerated by some pregnant women, just physically.
Right, lying still for that long. What about cardiac catheterization, like for angiograms or interventions?
When cardiac cath is required, the radial artery in the wrist is generally the preferred access site, especially after the first trimester.
Radial.
Yes. The estimated fetal radiation exposure from a diagnostic cardiac catheterization, again with abdominal shielding, is typically less than 1.5 milligray. If there's a suspicion of something like coronary artery dissection, it might be prudent to delay the procedure if it's clinically feasible and safe to do so.
Okay. And electrophysiology procedures for arrhythmias?
For EP procedures, it's really best to defer them until after pregnancy if possible. If intervention is absolutely necessary during pregnancy for refractory, life-threatening arrhythmias, then non-fluoroscopic mapping systems that don't rely heavily on X-ray guidance should be used whenever feasible. Experienced centers are key here.
It sounds like there are definitely strategies and alternatives to minimize radiation exposure when cardiac imaging or procedures are necessary during pregnancy. Okay, let's move on to risk stratification. How do doctors assess the overall risk for a pregnant woman who has heart disease? This seems absolutely critical.
Accurately assessing the risk of cardiovascular complications during pregnancy is crucial, yes. It really guides the entire management plan and helps ensure the best possible outcomes for both the mother and the baby.
What are the most common types of cardiac complications that might arise during pregnancy in women with heart disease? Are we talking heart attacks?
While heart attacks can happen, the most common non-fatal cardiac complications are actually heart failure and cardiac tachyarrhythmias, those abnormally fast heart rhythms we talked about.
Heart failure and arrhythmias. Okay. What about the worst outcome, maternal death?
Encouragingly, large studies have shown that the maternal mortality rate in women with heart disease during pregnancy is relatively low in high-resource settings, maybe around 1% or less.
1% or less. That's still higher than the general population, though, right?
Oh, yes, significantly higher. And it's important to acknowledge that this risk isn't uniform.
How so? Are there differences in the risk depending on where someone lives or their access to health care?
Yes, unfortunately, the rates of maternal cardiac complications tend to be significantly higher in low to middle income countries and in populations with reduced access to quality specialized health care. This really highlights the critical need for equitable access to expert cardiac and obstetric care for pregnant women everywhere.
Absolutely. A major health equity issue. So, what are the key factors that clinicians use to predict a specific pregnant woman's risk of experiencing cardiovascular complications?
Several factors are really important predictors. These include the woman's specific pre-existing cardiac diagnosis and history, her New York Heart Association, or NYHA functional class.
Right, the symptom severity scale.
Exactly. Also, her baseline oxygen saturation levels, particularly if she has cyanotic heart disease, and specific findings from her echocardiogram, like how well her heart is pumping or the severity of valve issues.
You mentioned NYHA functional class earlier. Just as a quick reminder for everyone, what are the different classes?
Sure. The NYHA functional classification system categorizes patients with heart disease based on how much their symptoms limit their physical activity. Class I means no limitation. Class 2, slight limitation. Class 3, marked limitation. And Class 4 means they have symptoms even at rest.
Got it. So a woman starting pregnancy already in NYHA class 3 or 4 would generally be at much higher risk.
Definitely. Higher pre-pregnancy functional class is a strong predictor of problems.
Are there specific risk scoring systems that are used to try and formalize this risk assessment, maybe put a number on it?
Yes, several risk scores and classification systems have been developed to help predict maternal cardiovascular complications in a more standardized way. One of the earliest and most widely used is the original CarPreg risk score that stands for cardiac disease in pregnancy.
Harpergate, okay.
This score uses 4 key predictors to classify a pregnancy as low, intermediate, or high risk for cardiac events.
And what are those 4 predictors in the original CarPreg score?
The original CarPreg score considers 1. A prior cardiac event like heart failure, stroke, or arrhythmia. 2. A baseline NYHA functional class worse than 2, or the presence of cyanosis. 3. Left heart obstruction, like significant valve stenosis. And 4. Reduced systemic ventricular systolic function, meaning the main pumping chamber is weak.
Okay, so it takes into account history, functional status, specific types of lesions, and heart function. Is there a newer version? Things evolve, right?
Yes, the CarPreg 2 risk score is a more comprehensive and updated tool. It incorporates a broader range of predictors, including functional factors, specific characteristics of the cardiac lesion itself, and even aspects of the care process. It calculates a risk based on weighted scores across 10 different variables.
10 variables. That sounds much more detailed. Can you give us a few examples of the types of factors CarPreg 2 considers that the original didn't?
Certainly. CarPreg 2 adds things like the presence of a mechanical prosthetic valve, the use of anticoagulation therapy throughout pregnancy, whether the NYHA class worsens during pregnancy, late maternal age, smoking, multiple gestation, and lack of expert cardiac assessment before 20 weeks.
Wow, okay. It sounds like it really tries to capture a much more complete picture of the individual's overall risk profile, including care factors. Are there other risk classification systems besides the CarPreg scores?
Yes, another widely used system is the Modified World Health Organization, or MWHO, classification system. This system is a bit different. It relies more on expert consensus to categorize specific maternal cardiac conditions into 5 risk classes.
5 classes. How do those work?
They range from Class 1, which includes conditions with very low risk, like an uncomplicated small hole between the heart chambers or successfully repaired simple lesions, all the way up to Class 4, which includes conditions where pregnancy poses an extremely high risk of maternal mortality or severe morbidity, and pregnancy is therefore contraindicated. There's also a Class 2, 3 for intermediate risk lesions.
So MWHO is more of a classification by condition rather than a numerical score based on individual factors. Has there been any research comparing the accuracy of these different risk assessment tools, like CarPreg 2 versus MWHO?
Yes, there has been. A large study conducted in Canada directly compared the predictive accuracy of the CarPreg 2 risk score with the MWHO classification system in their population of pregnant women with heart disease.
And what did they find?
Interestingly, that study found that CarPreg 2 second demonstrated superior predictive accuracy for maternal cardiovascular complications compared to the MWHO classification in their cohort.
That's really good to know. It suggests that CarPreg 2, being more individualized with those 10 factors, might be a more refined tool for predicting risk in many cases. Now, how are these risk scores and classifications actually applied in managing pregnant women with heart disease? How do they guide clinical decision-making day to day?
The primary goal of this risk assessment, whichever system you use, is really to identify women who are at the highest risk of serious complications, so that the appropriate management strategies can be put in place right from the start, ideally even before conception.
Right. For example, if someone is identified as being very high risk, like that MWHO Class 4 category, what kind of interventions or recommendations might be considered?
For women with cardiac lesions that fall into MWHO Class 4, conditions like severe pulmonary arterial hypertension, severe systemic ventricular dysfunction, or certain types of aortic disease, pregnancy carries a prohibitively high risk of mortality.
So what's the recommendation then?
In these situations, pregnancy is generally discouraged. Preconception counseling is absolutely vital to discuss these risks and the importance of highly effective contraception. If a pregnancy does occur in these women, termination is often considered the safest medical option for the mother.
That's a very difficult conversation, I'm sure, and these women require the highest level of care.
Absolutely. They need highly specialized care provided by a multidisciplinary maternal heart team, ideally at a tertiary referral center with experience in managing these complex cases.
Okay, so that's the extreme high-risk group. What about women who don't fall into that category? Maybe they are intermediate or even lower risk. How are the risk scores like CARPREG-2 used then?
For pregnancies in women without these ultra-high-risk lesions, the CARPREG-2 risk score can be a really valuable tool. The calculated risk percentage can help guide the intensity of monitoring needed, the frequency of follow-up visits, the need for specialized consultations, and importantly, the planning for labor and delivery.
So a higher score might mean more frequent echoes or cardiologist visits?
Exactly. But it's important to remember that the score is just one piece of the puzzle. Clinical judgment and consideration of other individual factors are also crucial. It's not just about the number.
What kind of individual factors might modify how a CARPREG-2 score is interpreted or acted upon? You can't just plug numbers into a calculator, right?
Precisely. Factors such as the results of objective testing, like exercise stress testing, the patient's adherence or likely adherence to medical recommendations, the presence of other medical conditions or comorbidities like diabetes or obesity,
Okay.
socioeconomic factors that might impact access to care or follow-up, the need for complex medications like anticoagulation, specific type of cardiac lesion and any prior repairs, and the presence of any late sequelae or complications from previous cardiac interventions. All of these need to be factored into the overall assessment and plan.
So it's really about using the score as a starting point and then layering in the whole clinical context. What about for clinicians who primarily use the MWHO classification system? How is risk further refined within those broader categories?
That's a great question. Even within the MWHO risk classes, A2, 2, 3, 3, 3, it's important to incorporate those general predictors of cardiovascular complications we talked about earlier, like a prior history of heart failure or significant cardiac arrhythmias, to further stratify risk and guide management. A woman in MWHO Class 2 with a history of heart failure is higher risk than another woman in Class 2 without that history, for example.
That makes perfect sense. It's about using the available tools, whether it's a score or a classification, and then using clinical acumen to layer in individual patient characteristics to get the most accurate and nuanced understanding of their specific risk. Okay, now let's talk about the actual management recommendations for pregnant women with heart disease. This is where the rubber meets the road. What are the key aspects of care that need careful consideration?
Effective management really requires a comprehensive and, crucially, a multidisciplinary approach. Key elements include very careful consideration of cardiovascular medications, what's safe, what's not.
Right, we touched on that.
Determining the appropriate site for pregnancy care and delivery based on risk. The potential role of fetal echocardiography to check the baby's heart. And detailed planning for management during labor and delivery, as well as the critical postpartum period.
Let's start with cardiovascular medications again, maybe in a bit more detail. We mentioned some contraindications earlier. Can you elaborate on which drugs are generally considered safe to use during pregnancy and which ones must be avoided?
Okay, let's break it down. Several important cardiovascular medications are absolutely contraindicated during pregnancy due to potential risks to the developing fetus. Top of the list are ACE inhibitors drugs ending in prol, like lisinopril, and ARBs drugs ending in sartan, like losartan.
Why are they so bad?
They can cause significant fetal kidney problems, skull malformations, and growth restriction, especially if used in the second and third trimesters. They are considered teratogenic.
Definitely avoid. What else?
Aldosterone antagonists like spironolactone and epirinin should also be avoided. Statins, the cholesterol-lowering drugs, are generally contraindicated due to potential, though debated, teratogenic effects. Direct oral anticoagulants, the newer blood thinners often called DOACs.
Like Eliquis or Xarelto.
Exactly. Dabigatran, rivaroxaban, apixaban, edoxaban. They are generally not recommended due to concerns about them crossing the placenta and limited safety data in pregnancy. Bosentan, a medication used for pulmonary hypertension, is also a noteratogen and contraindicated.
Okay, that's a clear list of don'ts. What about beta blockers? They're used a lot in heart disease.
Beta blockers are commonly used. While one specific beta blocker, atenolol, has been associated with concerns about fetal growth restriction in some older studies, other beta blockers, particularly cardioselective ones like metoprolol, when used judiciously and with appropriate monitoring, generally don't seem to have major adverse effects on birth weight when you adjust for the mother's underlying condition. Labetalol is also very commonly used, especially for hypertension.
So most beta blockers are okay, but maybe avoid Atenol.
That's the general consensus, yes. Careful monitoring is always needed.
What about other common drugs, diuretics, aspirin?
Diuretics, like furosemide, may be needed for heart failure symptoms, but require careful monitoring of electrolytes and volume status. Low-dose aspirin is actually recommended for many women at high risk of preeclampsia.
Okay.
Warfarin, the older anticoagulant, is complex. It has the lowest risk of valve thrombosis for women with mechanical valves, but it crosses the placenta and carries a risk of embryopathy-specific birth defects if used between 6 and 12 weeks of gestation. The risk is dose-dependent, lower with doses under 5 milligrams daily.
So timing is critical with warfarin.
Absolutely. Often it's switched to heparin during that critical 6-12-week window. Heparins, both low molecular weight heparin, LMWH, like enoxaparin and unfractionated heparin, don't cross the placenta, making them safer for the fetus. However, they might be slightly less effective than warfarin at preventing maternal valve thrombosis and require careful dose adjustments and monitoring, often with anti-ATSA levels.
Complex choices there. And you mentioned NSAIDs earlier.
Right. Non-steroidal anti-inflammatory drugs like ibuprofen should generally be avoided after 20 weeks, and definitely by 32 weeks, because they can cause premature closure of a fetal blood vessel called the ductus arteriosus.
Good to know. What about during breastfeeding? Are the rules different?
Yes, they can be. Interestingly, some medications that are contraindicated during pregnancy, such as ACE inhibitors, are actually considered safe for use during lactation because very little gets into the breast milk. Warfarin and heparin are also safe during breastfeeding, but others, like amiodarone or colchicine, should still be avoided. Always best to check specific drug compatibility.
That's a very comprehensive overview of medication safety. It's crystal clear that careful consideration and close collaboration between the cardiologist, obstetrician, and patient are absolutely essential when managing cardiovascular drugs during pregnancy and lactation. Okay, now let's talk about where a pregnant woman with heart disease should receive her care and deliver her baby. Does everyone need to go to a specialized center?
The ideal site of pregnancy care and delivery really depends heavily on the woman's individual risk stratification, based on those tools we discussed.
So for the highest risk women,
For women with high-risk cardiac conditions, think MWHO Class 3 or 4, or a high CarPreg 2 score exclusive care at a specialized tertiary referral center with a dedicated, experienced maternal heart team is strongly recommended. This team usually includes cardiologists, obstetricians specializing in high-risk pregnancy, MFMs, anesthesiologists, intensivists, and specialized nurses.
makes sense. They need all the expertise on hand. What about those with sort of intermediate or non-high risk conditions?
For those women, a model of joint care or shared care is often appropriate. This means the woman is followed by both her local obstetrician and the maternal heart team at the referral center. She might have key consultations or her delivery at the referral center, but some routine care locally. An initial comprehensive review by the heart team early in pregnancy is usually key to setting up this plan.
Okay, a collaborative approach. And for women deemed truly low risk, like maybe a successfully repaired simple defect years ago with no issues.
In cases where the cardiac risk is clearly identified as low, perhaps MWHO classy, an initial consultation with the maternal heart team to confirm the low-risk status and establish a clear plan might be sufficient. Then, ongoing obstetric care could potentially continue primarily with a local provider, assuming good communication channels are in place.
So it's really a tiered system based on the level of risk, aiming to match the intensity of care with the potential for complications. What about checking the baby's heart? You mentioned fetal echocardiograms. When are those specifically indicated in the context of maternal heart disease? Does every baby need one?
Not necessarily every baby. The indications for fetal echocardiography, which is that specialized ultrasound to assess the baby's heart structure and function in detail, are generally the same as those that would prompt genetic counseling or further fetal assessment. This includes situations like a known family history of congenital heart defects in parents or previous children, certain maternal medical conditions known to increase the risk, including many types of maternal congenital heart disease itself, exposure to certain medications early in pregnancy, or if any abnormalities are suspected on routine prenatal ultrasounds. The risk of congenital heart disease in the baby is higher if the mother has CHD, often around 3–5%, but can be higher depending on the specific maternal lesion.
Okay, so it's indicated when there's a known increased risk factor for the baby having a heart problem. Now let's move on to the critical period of labor and delivery itself. This seems like the time of maximum stress we talked about. What are the key management considerations for women with heart disease during this phase?
Absolutely. Labor and delivery require very careful planning and management. When possible, spontaneous vaginal delivery is generally the preferred mode of delivery for most women with heart disease.
Why is vaginal delivery preferred over a scheduled C-section?
Vaginal delivery generally involves less blood loss, a lower risk of infection and blood clots, and often a quicker recovery compared to cesarean section. The hemodynamic stress, while significant during contractions, can often be managed well with appropriate monitoring and support. Cesarean delivery is major abdominal surgery with its own set of risks.
Okay. But you mentioned there are rare cardiac indications for a cesarean.
Yes, cesarean delivery is typically reserved for specific obstetric indications, just like in women without heart disease. However, there are a few rare cardiac indications where vaginal delivery might pose a particularly significant risk.
What would be some examples of those?
These might include situations where the woman is anticoagulated with warfarin and hasn't had adequate time for it to wear off before delivery starts, as this significantly increases the risk of dangerous bleeding with a vaginal delivery or even an epidural.
Right, the bleeding.
Also, it might be considered in women with a severely dilated thoracic aorta, like in Marfan syndrome, where the intense straining of labor could theoretically increase the risk of aortic dissection or rupture, although the exact size threshold is debated.
Okay.
Other rare indications could be women with severe refractory heart failure that is poorly controlled despite maximal medical therapy going into labor, or those experiencing significant hemodynamic instability during labor that isn't responding to management.
So it's usually reserved for situations where vaginal delivery itself could be particularly dangerous due to bleeding risk, aortic issues, or severe instability. Is it better for labor to start naturally, or is induction of labor generally acceptable in women with heart disease?
Spontaneous onset of labor is generally preferred, as it often progresses more physiologically. However, induction of labor might be considered for specific logistical reasons, such as when the patient lives very far from the specialized hospital and needs to ensure delivery happens there, or when a specific multidisciplinary team needs to be assembled and available for a complex delivery. It might also be considered for maternal or fetal medical reasons near term. But the decision to induce should be made carefully, weighing the benefits against the potential risks, like a longer labor or increased need for interventions.
Okay. What about the use of invasive hemodynamic monitoring during labor and delivery, like those arterial lines you mentioned? Is that common?
Invasive hemodynamic monitoring, primarily with an arterial line to continuously monitor blood pressure second to second, might be considered for women with very high-risk cardiac conditions.
Such as?
Examples include those with severe left ventricular systolic dysfunction, a very weak heart pump, severe aortic or mitral stenosis, very tight valves, or significant pulmonary hypertension. In these cases, rapid changes in blood pressure or fluid status can be dangerous, and close monitoring is key.
So it's reserved for the most critical cases where that beat-to-beat blood pressure information is essential. What about central lines or pulmonary artery catheters, like a Swan-Ganz?
The routine use of central venous catheters or pulmonary artery catheters is actually rarely indicated in contemporary obstetric cardiology practice. They carry their own risks and often don't add enough actionable information beyond what can be gleaned from clinical assessment, non-invasive monitoring, and perhaps an arterial line in select cases.
Okay, so less invasive is generally better, if possible. What about continuous heart rhythm monitoring?
Continuous telemetry monitoring of the heart rhythm is crucial for women with known or suspected significant arrhythmias, or those at high risk of developing them during the stress of labor. This allows for prompt detection and treatment of any dangerous rhythm disturbances.
Makes sense. And what kind of monitoring is recommended immediately after delivery in that vulnerable postpartum period?
Postpartum monitoring in a specialized setting, like a coronary care unit, CCU, high dependency unit, HDU, or intensive care unit, ICU, is often recommended for women who are classified as being at high cardiac risk, ANG, MWHO 3 or 4, high CarpRig 2 ADRA score, or those who had complications during delivery.
Why is that specialized monitoring needed then?
Because, as we discussed, significant fluid shifts occur in the first few hours and days postpartum as the body gets rid of the extra pregnancy volume. This can precipitate heart failure or arrhythmias in susceptible women. Close observation allows for early detection and management of these issues. The duration of monitoring depends on the specific condition and clinical course.
That sounds like a very careful, proactive, and risk-stratified approach to managing pregnancy, labor, delivery, and the postpartum period in women with heart disease. It really highlights the need for that multidisciplinary team approach you mentioned.
Absolutely. Collaboration and communication between cardiology, obstetrics, anesthesia, and critical care are paramount for optimal outcomes.
So, when it comes to managing heart rhythm problems during pregnancy, the most important thing to grasp is that a highly personalized approach is, well, it's essential.
Right.
Treatment isn't a one-size-fits-all solution. Doctors need to carefully evaluate the specific type of arrhythmia a woman is experiencing and whether there are any underlying structural issues with her heart. This tailored strategy is just crucial for achieving the best possible outcomes for both mother and baby.
Okay, let's unpack this a bit further then. What happens when a pregnant woman's heart suddenly starts racing dangerously fast and her condition becomes unstable? Her body isn't getting enough blood.
Yeah, in those critical situations where a pregnant woman has a rapid heart rhythm and is hemodynamically unstable, meaning her heart isn't effectively pumping enough blood to keep her organs functioning properly, electrical cardioversion is the necessary and crucially a safe procedure to restore a normal heart rhythm.
Right.
While it might sound a bit alarming, it's a well-established and vital intervention in these urgent moments to quickly get the heart beating correctly again. The key takeaway here is that in critical situations of unstable rapid heart rhythm, this is a safe and life-saving intervention for both mother and baby.
And what about the opposite scenario? What if the heart rate drops too low during pregnancy? Is that a common concern?
Interestingly, bradycardias, or abnormally slow heart rhythms, are actually less common during pregnancy.
Oh, okay.
While they can occur, they are not typically as prevalent as tachyarrhythmias, which are the fast heart rhythms.
That's good to know. Now, many people rely on implanted devices like pacemakers or implantable defibrillators for their ongoing heart health. Are these devices generally safe to use throughout pregnancy and, during labor and delivery?
Yes, the good news is that both pacemakers, which help regulate a slow heart rhythm, and implantable cardioverter defibrillators, or ICDs, which can deliver an electrical shock to stop a life-threatening rapid heart rhythm, are considered safe for use throughout pregnancy and during labor and delivery.
Good.
Women who rely on these devices can generally continue to do so without an increased risk to themselves or their babies.
Here's where it gets really interesting, though. I recall reading about potential complications with pacemakers if certain surgical tools are used during delivery. Can you tell us more about that?
Yes, that's a very important point to be aware of. If electrocautery, which is a surgical technique using heat to stop bleeding during procedures, is used during the delivery process,
Right.
there's a potential risk of the pacemaker misinterpreting the electrical signals produced by the cautery device. This is known as oversensing.
Oh, okay.
So, to prevent any issues, it's absolutely crucial that magnets are readily available in the delivery room. Applying a magnet over the pacemaker can temporarily disable its sensing function, preventing any, inappropriate responses from the device during the procedure.
It's reassuring to know about the devices themselves.
Yeah.
But are there situations where these devices might encounter challenges during delivery?
Well, the main thing is that oversensing risk with cautery. Having the magnet handy is the key mitigation there.
So it's all about being prepared and having the right tools on hand. Now, I can imagine that sometimes managing these heart rhythm issues can become quite complex and require more than just medication. Are there instances where more invasive treatments become necessary during pregnancy?
Absolutely. While medication and the less invasive interventions we've discussed are often effective, there are occasionally cases where women with persistent and troublesome symptoms require more involved percutaneous, meaning, through the skin or even surgical interventions to address their arrhythmias.
Okay.
These are typically reserved for difficult or refractory cases, meaning cases that haven't responded adequately to standard medications and treatments.
And if these more invasive procedures are needed, what precautions are taken to protect the baby, especially when it comes to potential radiation exposure?
Yeah, minimizing radiation exposure to the developing fetus is always a paramount concern. Several important strategies are employed. Firstly, maternal abdominal lead shielding is used to directly protect the baby from any scatter radiation. Secondly, whenever it's clinically feasible, a radial artery approach, accessing blood vessels in the wrist rather than the groin, can be used, which typically reduces the amount of radiation exposure to the abdomen.
Interesting.
And finally, specific procedural techniques are utilized by the medical team to keep the radiation doses as low as reasonably achievable while still effectively treating the mother's cardiac condition.
That makes perfect sense. It sounds like medical teams are very careful to balance the necessary treatment for the mother with the utmost safety of the baby. Now, what about women who have severe problems with their heart valves? Can anything be done for them during pregnancy if medications aren't providing enough relief?
So for women who have severe symptomatic narrowing of their heart valves, like mitral, aortic, or pulmonary stenosis that isn't responding adequately to medication, there are interventions like balloon valvuloplasty that can be considered. This procedure involves threading a catheter with a balloon to the narrowed valve and then inflating the balloon to widen the opening and improve blood flow. In very carefully selected cases, percutaneous valve insertion, where a new valve is placed using a catheter, might also be considered to relieve the obstruction.
But it sounds like these are not routine procedures during pregnancy. Are there significant risks involved with these types of interventions?
Yes, precisely. These types of interventions during pregnancy carry notable risks, which is why they should only be performed at medical centers with a high level of expertise in these specific procedures.
Hmm.
Reported complications include things like acute heart failure, the development of new and potentially dangerous arrhythmias, cardiac tamponade, which is a dangerous compression of the heart due to fluid buildup around it, and sadly, in rare instances, even death.
That sounds incredibly serious. So what
Sure.
kind of backup and planning needs to be in place if these procedures are deemed absolutely necessary during pregnancy?
Given the potential for serious complications, having a full obstetric backup team immediately available is absolutely essential.
Right.
This is because these procedures can sometimes trigger a very rapid onset and progression of labor, and the medical team needs to be fully prepared to manage both the mother's critical cardiac condition and the baby's delivery, potentially on very short notice.
Okay, so those are more interventional approaches through catheters.
Yeah.
What about actual open heart surgery during pregnancy? Is that ever a necessary option?
Cardiac surgery during pregnancy is really considered a last resort. It's only undertaken when there are absolutely no other viable treatment options because it carries a significant risk of fetal mortality, estimated to be around 20% of cases.
Wow, 20%.
Yeah. The potential impact on the baby is a major consideration, and the decision to proceed with surgery during pregnancy is never taken lightly. The core insight is that surgery is a last resort, and the decision-making heavily prioritizes fetal well-being, often favoring postpartum intervention when possible.
And are there specific factors that might make open heart surgery even riskier for the baby if it has to be performed during pregnancy?
Yes, several factors have been identified that are associated with a higher risk of fetal mortality during cardiac surgery in pregnant women. These include the need for urgent surgical intervention, the presence of other underlying medical conditions in the mother known as maternal comorbidities,
Okay.
and if the surgery has to be performed earlier in the pregnancy, particularly during the first or second trimester.
So if open heart surgery is unavoidable during pregnancy, are there any strategies that medical teams can use to try and minimize the risk to the baby?
Absolutely. When cardiac surgeries is necessary during pregnancy, a number of techniques are employed to mitigate fetal risk as much as possible. These include using pulsatile perfusion, which is a technique that tries to mimic the natural pulsatile way blood flows through the body, maintaining a high pump flow during cardiopulmonary bypass, avoiding hypothermia on bypass, keeping the mother's body temperature closer to normal during the procedure, minimizing the total amount of time the mother is on cardiopulmonary bypass, and continuous fetal monitoring throughout the entire surgical procedure.
That sounds like a lot of careful and specialized management. What about later in the pregnancy? Does the stage of pregnancy change the approach to potential cardiac surgery?
Yes, as the pregnancy progresses, particularly later in gestation when the baby is more developed, the preferred strategy often shifts if cardiac surgery becomes necessary.
Right.
In many cases, if it's feasible and safe for the mother's condition, the medical team will aim to deliver the baby first and then proceed with the mother's cardiac surgery in the immediate postpartum period.
Oh, I see.
This approach can significantly reduce the risks associated with performing major surgery while the baby is still in the womb.
Okay, that gives us a really good understanding of how arrhythmias and more significant cardiac issues are managed during pregnancy. Now, let's move on to another really critical area of concern: hypertension.
Right. Hypertensive disorders of pregnancy are a major global health concern. They are indeed one of the leading causes of both maternal deaths and deaths of babies around the time of birth worldwide.
Yeah.
In fact, as we mentioned at the beginning, in high-income countries, these disorders are responsible for a significant 16% of all maternal deaths, really underscoring the seriousness of this issue. So the critical distinction for you to understand is that high blood pressure in pregnancy isn't just one thing. The timing and underlying cause are crucial for management.
And it's not just one type of high blood pressure that can occur during pregnancy, right? I remember seeing that there are different categories.
That's correct. Hypertensive disorders of pregnancy are broadly classified into four main categories. The first and perhaps most well-known is preeclampsia and its more severe form, eclampsia. The second is gestational hypertension, which is high blood pressure that develops after 20 weeks of pregnancy in a woman who previously had normal blood pressure. Then there's chronic hypertension, which is high blood pressure that was present before the pregnancy or was diagnosed before the 20th week. And finally, there's chronic hypertension with superimposed preeclampsia, which occurs when a woman with pre-existing chronic hypertension develops the additional features of preeclampsia during her pregnancy.
So, how is hypertension actually defined in the context of pregnancy? What are the specific blood pressure numbers that doctors look for to make a diagnosis?
Okay, so hypertension in pregnancy is defined by specific blood pressure readings. It's a systolic blood pressure, that's the top number, of 140 millimeters of mercury, millimeter Hg or greater, or a diastolic blood pressure, the bottom number, of 90 millimeter Hg or greater,
Okay.
based on two separate measurements taken at least 4 hours apart. However, there's an important exception for severely elevated blood pressure.
Right.
If the blood pressure reading is very high, a systolic of 160 millimeter Hg or greater, or a diastolic of 110 millimeter Hg or greater, then the second measurement can be taken much sooner, within just 15 minutes.
Got it. And what's the proper way to remeasure blood pressure if that initial reading is high, but not in that severely elevated range?
Good question. If the initial blood pressure reading shows a non-severe elevation, so 40/90 or higher, but below 160/110, the blood pressure should be remeasured in the arm that had the higher reading after an interval of at least 15 minutes. It's important to allow the woman to rest and relax in a comfortable position before the repeat measurement is taken.
That makes sense. I'm guessing that just because a woman has one high blood pressure reading during pregnancy, it doesn't automatically mean she has hypertension.
Exactly. It's actually quite common for a woman to have a first blood pressure reading that's 14/90 or greater, but then subsequent measurements taken after she's had a chance to rest and is feeling less anxious will actually be within the normal range. This really highlights the importance of those repeat measurements and not immediately concluding that a woman has hypertension based on a single elevated reading in the doctor's office.
I've also heard of something called white coat hypertension, where people get nervous in a medical setting and their blood pressure goes up. Does that play a role in diagnosing hypertension during pregnancy?
Yes, white coat hypertension, where a person's blood pressure is elevated in a medical setting but is normal when measured at home, can indeed occur during pregnancy.
Right.
For women who have persistently elevated blood pressure readings of 490 millimeter Hg or less before 20 weeks of pregnancy, ambulatory blood pressure monitoring can be a very useful tool.
Okay. What's that?
Well, this involves wearing a blood pressure cuff that takes readings at regular intervals over a 24-hour period, providing a much more accurate picture of a woman's blood pressure throughout her daily activities. It really helps to differentiate between true chronic hypertension and white coat hypertension.
That sounds like a really helpful way to get a clearer picture over time. What about women who already had high blood pressure before they became pregnant? Can their blood pressure behave differently in the early stages of pregnancy?
That's a very insightful question. Women with pre-existing chronic hypertension might actually experience a falsely normal blood pressure reading early in pregnancy, particularly around the 12th week of gestation.
Really? Why that?
Well, it can happen because of the normal physiological changes of pregnancy, specifically a reduction in systemic vascular resistance, which can temporarily lower blood pressure even in women with underlying hypertension. So it's important for doctors to be aware of this potential dip and not assume that a normal reading early on means their chronic hypertension has resolved.
And finally, what blood pressure numbers during pregnancy would be considered a real red flag requiring immediate medical attention?
Pregnant women with severe hypertension, defined as a blood pressure of 106 to 110 millimeter Hg or greater that persists for at least 15 minutes, require urgent medical attention. These severely elevated readings indicate a significant and immediate risk of serious complications for both the mother and the baby, and prompt evaluation and management are absolutely crucial in these situations.
Okay, that's a comprehensive look at hypertension during pregnancy. Now let's delve into preeclampsia, which we've mentioned is a major concern. What exactly defines preeclampsia?
Preeclampsia is defined by a specific set of criteria. Firstly, it involves the development of new onset hypertension, that's a systolic blood pressure of 140 millimeter Hg or greater, or a diastolic blood pressure of 90 millimeter Hg or greater after 20 weeks of gestation in someone who was previously known to have normal blood pressure.
Right.
In addition to this new onset hypertension, the diagnosis also requires either the development of new onset proteinuria, which is the presence of a significant amount of protein in the urine,
Okay.
or the presence of new signs or symptoms indicating end organ damage.
So both high blood pressure that starts after 20 weeks and protein in the urine are usually needed to diagnose preeclampsia.
Not necessarily. The current guidelines actually emphasize that if a woman develops new signs or symptoms that indicate damage to her organs, like severe headaches, vision changes, kidney problems, liver abnormalities, or problems with her blood clotting after 20 weeks of pregnancy, along with new onset hypertension,
Hmm.
then the diagnosis of preeclampsia can be made even if a significant amount of protein is not detected in her urine.
Oh, interesting.
The focus has really shifted to recognizing the broader impact of the condition on the mother's body beyond just blood pressure and protein levels.
That's an important clarification. I also noticed a note about how the timing can sometimes overlap with gestational and chronic hypertension.
Yeah.
It sounds like things can get a bit confusing with the definitions.
You're right, there can be some overlap in the timing, which can sometimes make it challenging to differentiate between these conditions early on. While gestational hypertension is typically defined as high blood pressure developing after 20 weeks in someone with previously normal blood pressure, previously undiagnosed chronic hypertension might not become apparent until after 20 weeks as well, especially if a woman's blood pressure dipped slightly in the second trimester, which can happen normally in pregnancy.
Right.
It's the persistence of hypertension beyond the postpartum period that usually confirms a diagnosis of chronic hypertension.
So what is currently thought to actually cause preeclampsia? What's the underlying biological mechanism?
Well, the currently proposed mechanism for preeclampsia centers around the idea of uteroplacental ischemia.
Yeah.
This means that there's a reduced blood flow to the placenta, which is the vital organ that provides oxygen and nutrients to the developing baby.
Okay.
This inadequate blood flow is thought to trigger an imbalance in various substances produced by the placenta, specifically angiogenic factors, which promote the growth of new blood vessels,
Hmm.
and anti-angiogenic factors, which inhibit this growth. This imbalance is believed to lead to widespread dysfunction of the mother's blood vessels and the various signs and symptoms that we see in preeclampsia.
It sounds like a cascade of events that originates with a problem in the placenta. Now, I know that preeclampsia can range in severity. What are the factors that make a case of preeclampsia severe?
Right. Severe preeclampsia is indeed considered a significant obstetrical emergency. It's characterized by more extreme elevations in blood pressure, as well as more pronounced signs of end organ damage in the mother.
Like what kind of damage?
These severe features can affect the brain, causing neurological symptoms, the liver, leading to abnormal liver function tests, the kidneys, resulting in reduced kidney function, and the blood, potentially causing clotting problems or a drop in platelet count.
Wow.
Prompt recognition and aggressive management are absolutely critical in these cases to prevent serious and potentially life-threatening complications for both the mother and the baby.
And what about HELLP syndrome? I've heard that term mentioned in connection with severe preeclampsia. What is it?
HELLP syndrome is considered a particularly severe and life-threatening variant of preeclampsia. The acronym HELLP stands for hemolysis, which is the breakdown of red blood cells, elevated liver enzymes, indicating damage to the liver, and low platelet count, meaning a reduced number of platelets in the blood, which are essential for clotting.
Okay.
HELLP syndrome typically presents in the third trimester of pregnancy, but it's also important to be aware that it can sometimes develop or even worsen in the postpartum period after the baby has been born.
And eclampsia, how does that relate to preeclampsia? Is it just a more severe form?
Eclampsia is the most serious neurological complication of preeclampsia. It's defined as the occurrence of new onset seizures or convulsions in a woman who has been diagnosed with preeclampsia.
Right.
Eclampsia is a very significant cause of maternal death, particularly in low-resource settings where access to timely and appropriate medical care may be limited.
It's quite sobering to think about how serious these conditions can be.
Yeah.
Is it always the case that a woman will have noticeable hypertension and protein in her urine before developing HLLP or eclampsia?
Interestingly, no. In a notable minority of cases, HELLP syndrome and eclampsia can actually occur without the woman having had significantly elevated blood pressure readings or a large amount of protein in her urine beforehand.
Really?
Yeah. This can make these conditions particularly challenging to recognize and diagnose, underscoring the importance of being vigilant for the other potential signs and symptoms of preeclampsia in its severe forms, even if the typical markers aren't as prominent.
That's a really crucial point. It sounds like relying solely on blood pressure and urine tests might not always catch all the dangerous cases.
Mm.
Now let's talk about managing hypertension during pregnancy. What's the general approach to treatment once a woman is diagnosed?
For women who are diagnosed with less severe hypertension during pregnancy, the initiation of pharmacotherapy or treatment with antihypertensive medication is often considered. There are several first-line antihypertensive agents that are generally considered safe to use during pregnancy to help lower blood pressure.
And are there clear, universally agreed upon guidelines on exactly when to start medication for less severe hypertension and what the ideal blood pressure target should be once a woman is on treatment?
Well, this is an area where current medical guidelines actually differ somewhat among various organizations and regions.
Huh.
There isn't a single universally agreed upon blood pressure threshold at which medication should definitely be started for women with less severe hypertension during pregnancy, nor is there one specific optimal blood pressure target that all guidelines recommend aiming for with treatment. Different medical societies and international expert groups have slightly varying recommendations based on their interpretation of the available evidence.
That's interesting. So what does the research evidence actually say about how tightly blood pressure should be controlled during pregnancy? Is aiming for a very low blood pressure always better?
Research has shown that very tight control of blood pressure, specifically aiming for a diastolic blood pressure below 85 mmHg, did not lead to improved outcomes for either the mother or the baby when compared to a more moderate or less strict approach to blood pressure control.
Okay.
However, tighter blood pressure control did demonstrate a benefit in reducing the risk of the mother developing severe hypertension during pregnancy.
Right.
So it seems there's a balance to be struck between preventing severe hypertension and avoiding excessively low blood pressure.
And what are some of the specific blood pressure goals that are recommended by different guidelines around the world?
Currently, the optimal goal for blood pressure therapy during pregnancy varies between different regions. For example, guidelines in the U.S. tend to suggest a target systolic blood pressure in the range of 140 to 150 millimeter beat Hg and a diastolic blood pressure in the range of 90 to 100 millimeter Hg. European guidelines generally recommend aiming for a blood pressure below 190 millimeter Hg. Canadian recommendations, on the other hand, have often focused more on the diastolic blood pressure, suggesting a target of less than 85 millimeter Hg.
Wow.
These differences highlight the ongoing evaluation of the research and the nuances involved in managing hypertension during pregnancy.
That really underscores just how complex and evolving this area of medicine is. Now, I recall reading something about blood volume in women with preeclampsia. Is it usually increased, as you might expect with high blood pressure, or is it actually different?
That's a common misconception. While it might seem intuitive that high blood pressure would be associated with an increased amount of fluid in the body, in reality, hemoconcentration, which is an increase in the concentration of red blood cells in the blood rather than hypervolemia or an excess of fluid, is actually a frequent finding in patients with preeclampsia. This is thought to be due to fluid shifting out of the blood vessels. This finding has important implications for how these women are managed, particularly regarding the administration of intravenous fluids.
That's a surprising but very important detail to understand. I also saw mentions of gynecologists' classifications and specific management algorithms for hypertensive disorders in pregnancy. Are those widely used by doctors?
Yes, various classifications and detailed management algorithms that have been developed by gynecological societies and other medical organizations are indeed widely used in clinical practice to help standardize the approach to diagnosing and managing hypertensive disorders during pregnancy.
Okay.
These tools provide a structured framework for clinicians to follow, although the specific details and recommendations can vary somewhat between different guidelines, such as the North American recommendations that were also referenced.
Okay, so now that we've talked about managing hypertension and preeclampsia, let's move on to the very important topic of prevention, specifically the prevention of preeclampsia in women who are at higher risk. Are there any strategies that have been shown to be effective in reducing this risk?
Yes. For the prevention of preeclampsia, low-dose aspirin has been shown to be beneficial for women who are identified as being at higher risk of developing the condition.
Right.
Current recommendations suggest that low-dose aspirin should be initiated between 12 and 16 weeks of gestation, and ideally before the end of 20 weeks, and continued daily until at least 36 weeks of pregnancy.
Hmm.
This preventative measure is specifically recommended for women who have any established high-risk factors for preeclampsia.
And what are some of those specific high-risk factors that would lead doctors to recommend low-dose aspirin for preeclampsia prevention?
The established high-risk factors include things like having chronic hypertension before pregnancy, a history of preeclampsia in a previous pregnancy, being pregnant with more than one baby, so multifetal gestation,
Right.
having pre-existing diabetes mellitus, either type 1 or type 2, having chronic kidney disease, having certain autoimmune diseases such as lupus or antiphospholipid syndrome, or having a history of preterm birth before 34 weeks of gestation in a previous pregnancy.
Okay. What about women who don't have any of those high-risk factors, but might have some other factors that increase their risk moderately? Is low-dose aspirin recommended for them as well?
Yes, low-dose aspirin is also recommended for women who have more than one moderate risk factor for preeclampsia.
Okay. Like what?
These moderate risk factors include being pregnant for the first time, that's nulliparity, having a body mass index, BMI, greater than 30 at the start of pregnancy, having a family history of preeclampsia in a mother or sister, being aged 35 years or older, having a low socioeconomic status, or having certain other factors in their personal medical history that might suggest an increased risk.
Got it.
The presence of more than one of these moderate risk factors elevates a woman's overall risk for preeclampsia, making low-dose aspirin a reasonable and recommended preventive strategy.
That's really helpful information for women and their healthcare providers to know. Now, what about the timing of delivery? For women who develop gestational hypertension or preeclampsia during their pregnancy, how is that important decision made?
In women who develop gestational hypertension or preeclampsia, the decision of when it's best to deliver the baby versus trying to continue the pregnancy with close monitoring depends very heavily on two key factors.
Okay.
The first is whether or not there are severe features of preeclampsia present, as these indicate a higher and more immediate risk of serious complications for the mother. The second crucial factor is the gestational age of the baby, how far along the pregnancy is.
Right.
These two elements are carefully weighed by the medical team to determine the optimal timing for delivery that best balances the risks to both the mother and the baby.
And what kind of medical follow-up is typically needed after delivery for women who experienced hypertension during their pregnancy? Is it just something that goes away after the baby is born?
Well, it's really important for women who experienced any form of hypertension during pregnancy to have continued medical follow-up even after the baby is born.
Mhm.
This often includes ambulatory follow-up where they have regular checkup appointments and/or home blood pressure monitoring to ensure their blood pressure returns to a normal range. If a woman's blood pressure remains elevated in the postpartum period, generally defined as 150-100 millimeter Hg or higher, then antihypertensive medication should likely be continued.
Okay.
Furthermore, because hypertension during pregnancy can sometimes be an early indicator of an increased risk for developing chronic hypertension and other cardiovascular diseases later in life, these women require longitudinal follow-up with their primary care physicians. And they should really focus on modifying any other modifiable cardiovascular risk factors they may have, like weight, diet, and exercise habits.
That makes a lot of sense. Pregnancy can almost act like a stress test for the cardiovascular system, sometimes revealing underlying vulnerabilities. Now, let's shift our focus to another important area, cardiomyopathies. What are some of the common types of cardiomyopathy that can be seen in women of childbearing age?
Yeah, common pre-existing cardiomyopathies that can be present in women of childbearing age include dilated cardiomyopathy, or DCM, where the heart muscle becomes enlarged and weakened,
Okay.
hypertrophic cardiomyopathy, HCM, which is characterized by an abnormal thickening of the heart muscle, often making it harder for the heart to relax and fill with blood,
Right.
and cardiomyopathies that are directly related to pre-existing congenital heart disease or valvular heart disease. These underlying conditions can have significant implications for how a woman's heart handles the stresses of pregnancy.
Are there other, perhaps less common types of cardiomyopathy that can also affect women during their childbearing years?
Yes, there are several less common causes. These include ischemic cardiomyopathy, caused by reduced blood flow to the heart muscle, often due to coronary artery disease, tachycardiac-induced cardiomyopathy, which can develop from a persistently rapid heart rate over time, arrhythmogenic right ventricular cardiomyopathy, ARVC,
Okay.
non-compaction cardiomyopathy, a rare condition where the heart muscle doesn't develop properly in the womb, restrictive cardiomyopathy, where the heart muscle becomes stiff, and in certain regions, cardiomyopathy related to Chagas disease can also be a concern.
And then there's peripartum cardiomyopathy. That's a specific type that can develop around the time of pregnancy itself, right?
Exactly. Peripartum cardiomyopathy, often called PPCM, is a distinct condition that develops de novo, meaning it arises for the first time either during pregnancy itself or within the first few months after childbirth. It's a diagnosis we'll definitely discuss in much more detail a little later.
Okay. Given all these different types of cardiomyopathy, it sounds like pregnancy can potentially pose significant risks for women who have these underlying heart muscle conditions.
That's absolutely correct. Pregnant women who have any type of cardiomyopathy are at an increased risk for experiencing both maternal complications like heart failure and arrhythmias and adverse fetal outcomes. Therefore, it's absolutely crucial that these women undergo careful preconception risk stratification by a cardiologist and receive thorough counseling before they even plan to become pregnant. This allows them to fully understand the potential challenges and to develop the best possible management plan with their medical team.
Let's focus in on hypertrophic cardiomyopathy, or HCM. What are some of the key things that women with this condition and their doctors need to be aware of when considering pregnancy?
Okay, so hypertrophic cardiomyopathy is an inherited condition, typically passed down through families in an autosomal dominant pattern.
Meaning?
This means that if one parent has HCM, there's a 50% chance that each of their children will also inherit the genetic mutation that causes the condition. Because of the significant risk of genetic transmission, it's a very important topic to discuss during preconception counseling. Some women with HCM may choose to consider preimplantation, genetic screening, and in vitro fertilization as options to reduce the risk of passing the condition on to their children.
I know that HCM can affect the heart in different ways from person to person. What are some of the specific potential issues that can arise during pregnancy in women who have HCM?
Yeah, the way that HCM manifests and affects the heart's function can be quite variable. Some women with HCM may have a significant obstruction in the left ventricular outflow tract, restricting blood flow leaving the heart.
Okay.
Others may primarily experience diastolic dysfunction, where the heart muscle has difficulty relaxing, or systolic dysfunction, where it doesn't squeeze as effectively. Significant mitral regurgitation, leakage through the mitral valve, can also be present. During pregnancy, the most common cardiac complications seen in women with HCM include atrial fibrillation, that irregular rhythm, and heart failure.
Those sound like serious complications.
Yeah.
What is the general risk of maternal mortality for pregnant women with HCM?
Well, while maternal mortality in women with HCM during pregnancy is fortunately rare overall in modern medical practice, it has been reported in some cases, particularly in women who have certain high-risk features.
Okay.
However, it's really important to emphasize that the vast majority of women with mild to moderate forms of HCM do not experience significant cardiac issues during their pregnancy.
That's definitely reassuring to hear.
Yeah.
But it sounds like a very careful assessment before pregnancy is still crucial for some women with HCM.
Yeah.
What are those specific high-risk features that you mentioned earlier?
Right. Women with HCM who have high-risk features such as severe thickening of the left ventricle muscle, a history of unexplained fainting spells, syncope, a prior episode of ventricular tachycardia,
Okay.
or a significant obstruction in the left ventricular outflow tract are considered to be at a higher risk of developing cardiac complications during pregnancy. These women require a very careful and thorough assessment by a cardiologist before they even consider conceiving to fully understand their individual risk profile and develop a tailored management strategy.
What about the considerations for anesthesia and labor for women with HCM, particularly then who have a significant outflow tract obstruction? Are there any special approaches that are recommended?
Yes. In women with severe obstruction in the left ventricular outflow tract due to HCM, epidural anesthesia should be used with caution during labor.
Why is that?
Because epidurals can sometimes lead to a drop in blood pressure, which can paradoxically worsen the outflow tract obstruction in HCM and lead to further hemodynamic instability.
Ah.
Similarly, oxytocin, often used to induce or augment labor, can also potentially cause hypotension and an increase in heart rate, so it should be administered as a slow and carefully titrated intravenous infusion in these women, with close monitoring of their blood pressure and heart rate.
And during the actual delivery process, are there any specific maneuvers or approaches that should be avoided in women with obstructive HCM?
Yeah, in women with obstructive HCM, it's generally advised to avoid Valsalva maneuvers during the second stage of labor.
What are those again?
Those maneuvers involve forceful exhalation against a closed airway, like when straining during pushing. They can decrease the amount of blood returning to the heart, potentially worsening the outflow tract obstruction and leading to a drop in blood pressure.
Right.
Therefore, a facilitated second stage of labor, where interventions like vacuum extraction or forceps are used to assist delivery, might be preferred to shorten the pushing phase and minimize the need for prolonged Valsalva maneuvers.
Okay, that's really important information for managing labor and delivery in women with obstructive HCM. Now, let's move on to peripartum cardiomyopathy, or PPCM, which is a type of heart muscle weakness that develops around the time of pregnancy. What exactly defines this condition?
Okay, PPCM. Peripartum cardiomyopathy is defined as a weakening of the heart muscle, a cardiomyopathy that develops de novo, so for the first time either during pregnancy itself or within the first few months after childbirth, typically within the first 3 to 5 months postpartum. The key diagnostic features are left ventricular systolic dysfunction, meaning the main pumping chamber doesn't squeeze effectively, with a left ventricular ejection fraction, LVEF, of less than 45%,
Okay.
along with the presence of signs and symptoms of heart failure, like shortness of breath and swelling. Women with PPCM are also at an increased risk for developing embolic events, like blood clots.
So, is PPCM a diagnosis of exclusion? What does that term mean in this context?
Yes, PPCM is considered a diagnosis of exclusion. This means that before a diagnosis of peripartum cardiomyopathy can be definitively made, other practical causes of heart failure that can occur during pregnancy or postpartum need to be carefully ruled out.
Like what?
This could include pre-existing heart conditions that were previously undiagnosed, ischemic heart disease, viral infections of the heart muscle, myocarditis, or other underlying medical conditions that might explain the new onset of heart muscle weakness.
Are there any specific risk factors that seem to make some women more susceptible to developing peripartum cardiomyopathy?
Several risk factors have been identified that appear to increase a woman's likelihood of developing PPCM. These include older maternal age, being of African American race, having a multigestational pregnancy, carrying twins or more, Right. having a history of preeclampsia or gestational hypertension during the pregnancy, and a history of pre-existing hypertension. However, it's important to remember that PPCM can also occur in women who don't have any of these identifiable risk factors, so all pregnant and postpartum women should be aware of the potential symptoms.
And what is currently known about the cause of PPCM? Is there a clear understanding of why some women develop this condition around the time of pregnancy?
Unfortunately, the exact underlying cause of peripartum cardiomyopathy remains largely unknown.
Huh.
However, there are several potential mechanisms that have been proposed and are currently being actively investigated. These include nutritional deficiencies, viral myocarditis, autoimmune processes where the body's immune system attacks its own heart tissue,
Wow.
and various vascular and hormonal processes that are unique to pregnancy and the postpartum period. It's likely that PPCM is a multifactorial condition, probably resulting from a combination of several contributing factors rather than a single cause.
That makes sense given the significant physiological changes that occur during and after pregnancy. What is the typical approach to treating peripartum cardiomyopathy?
The treatment for peripartum cardiomyopathy is generally similar to the standard medical management of heart failure from other causes.
Okay.
This typically involves using medications such as diuretics to help reduce fluid overload, beta blockers to slow the heart rate and improve function, and afterload reduction medications like ACE inhibitors or ARBs, although these are generally started after the baby is born due to potential risks in pregnancy to help the heart pump blood more easily. Anticoagulation might also be considered to prevent blood clots.
I recall reading something about the hormone prolactin and a specific fragment of it being implicated in the development of PPCM. Can you explain that potential link?
Yes, fascinatingly. Research using a mouse model that mimics PPCM identified a specific 16 kilodalton,
Mhm.
16 kilodalton fragment of the hormone prolactin, which is naturally produced in high levels during pregnancy and breastfeeding.
Okay.
This particular prolactin fragment was found to contribute to both dysfunction of the blood vessels and direct damage to the heart muscle cells in the mouse model.
Interesting.
Based on these findings, along with some small observational studies in humans, the use of bromocriptine, a medication that suppresses prolactin secretion, has been explored as a potential therapy for PPCM. The idea is that by reducing prolactin levels, and therefore this harmful fragment, it might help improve heart function.
That's a really intriguing connection between a key pregnancy hormone and a heart condition.
Mm.
What about the long-term outlook for women who develop peripartum cardiomyopathy? How often do they recover their heart function?
The degree and timeline of recovery of left ventricular systolic function in women with PPCM can be quite variable. Some women experience a full or near full recovery within months, while others may have persistent impairment. The North American investigators of pregnancy-associated cardiomyopathy, eyepiece to study, provided valuable insights. They found that approximately 70% of the women in their study had an LVEF greater than 50% 1 year after their initial diagnosis of PPCM, which is generally considered a significant recovery.
Are there any factors that doctors can assess at the time of diagnosis of PPCM that might give an indication of whether a woman is more likely to have good recovery?
Yes, the IPEX study also identified some important prognostic markers. These include having a baseline LVEF greater than 30% at the time of initial diagnosis,
Okay.
and having a left ventricular end diastolic dimension, basically the size of the chamber when full, that is less than 6.0 centimeters on echo. Women who present with these characteristics tend to have a more favorable long-term outcome.
What about the other women in the IPIC study who didn't have a full recovery of their heart function? What were their outcomes like 1 year after their diagnosis?
Unfortunately, the IPEX study also found that approximately 13% of the women had experienced a major adverse cardiac event, like hospitalization for heart failure or stroke, or had persistent severe cardiomyopathy, defined as an LVEF remaining below 35% at 1 year.
Wow.
This highlights that PPCM can have significant and lasting consequences for some women.
I also saw a note mentioning that mortality rates from PPCM tend to be higher in African American women compared to other racial groups. Is that a consistent finding in research?
Yes, unfortunately, studies have consistently reported higher mortality rates and a greater risk of adverse outcomes among African American women who develop PPCM compared to women of other racial backgrounds. The reasons for these disparities are not yet fully understood and are an active area of ongoing research.
This is clearly a very important area for continued research and improved understanding. What about the risks of having future pregnancies for women who have previously been diagnosed with peripartum cardiomyopathy?
Subsequent pregnancies do carry significant risks for women who have had prior PPCM, particularly for those whose left ventricular systolic function hasn't fully recovered.
Right.
In fact, pregnancy is generally contraindicated or strongly discouraged in women who have residual LV systolic dysfunction, meaning their heart's pumping function is still impaired after a previous episode of PPCM. This is due to the substantial risk of maternal mortality and recurrent heart failure.
Okay.
The heart may just not be able to handle the increased demands of another pregnancy. So, careful counseling about the risks and benefits of future pregnancies is absolutely essential.
That's a very serious consideration that impacts future family planning. I also noticed a reference to a chart on LVEF recovery in the source material. Does that chart provide more detailed information?
Yes, the reference chart on LVEF recovery visually compares the LVEF at 1 year after diagnosis in relation to the initial LVEF at diagnosis.
Yeah.
It typically shows the percentages of women who experience different degrees of recovery, like no recovery, partial recovery, and complete recovery. It helps visualize the spectrum of outcomes and how initial function might relate to recovery chances.
That sounds like a valuable visual tool. Now let's move on to a topic that thankfully is becoming increasingly feasible with medical advancements. Pregnancy after a heart transplant. What are some of the key medical considerations for women in this unique situation?
Yeah, pregnancy after a heart transplant is indeed possible and can be successful for some women, but it requires careful planning, close medical management, and a thorough understanding of the potential risks and challenges for both mother and baby.
What are the general medical recommendations regarding the timing of attempting pregnancy after a woman has undergone a heart transplant? Is there a recommended waiting period?
Generally, it is recommended that women wait for at least 1 year after the transplantation surgery before attempting pregnancy.
Okay, 1 year.
This waiting period allows the transplanted heart to stabilize, gives the body time to adjust to immunosuppressant medications, and allows any early complications like rejection or infections to be resolved.
Right.
Additionally, pregnancy is generally contraindicated in women at high risk of rejecting their transplant or who have evidence of baseline graft dysfunction, meaning the heart isn't functioning adequately even before pregnancy.
Preconception counseling seems like it would be absolutely essential in these cases. What are some of the key topics and potential risks that should be thoroughly discussed?
Oh, absolutely critical. Preconception counseling provides a crucial opportunity to discuss the potential risks to both the mother, including rejection, infections, medication complications, and to the baby, like potential medication effects, prematurity, and other issues.
Hmm.
It also allows for necessary adjustments to the medication regimen, as some immunosuppressants can be harmful to a developing fetus and may need to be switched beforehand.
Which ones?
Well, we'll get to that. Importantly, the counseling should also include an open and honest discussion about the mother's long-term life expectancy following the transplant, as this can be a significant factor in family planning.
I know that heart transplant recipients need to take immunosuppressant medications for life. Are there any specific concerns about taking these during pregnancy?
Yes, definitely significant concerns. One particular immunosuppressant, mycophenolate mofetil, is a known teratogen, meaning it can cause birth defects.
Right.
Therefore, it must be stopped prior to conception and switched to a safer alternative. If possible and clinically appropriate, azathioprine is often the preferred alternative immunosuppressant to use during pregnancy, as it's generally considered lower risk than mycophenolate.
And once a woman who has had a heart transplant does become pregnant, what kind of specialized medical follow-up and monitoring is typically required?
Frequent and very careful surveillance of their immunosuppressant medication levels is absolutely critical throughout the pregnancy.
Why is that?
Well, pregnancy causes significant changes in the body, including alterations in how drugs are distributed and metabolized. These changes can affect how much medication is actually in the bloodstream.
Okay.
So doses may need to be adjusted frequently throughout pregnancy and postpartum to maintain therapeutic levels enough to prevent rejection, but not so high as to cause toxic side effects for mother or baby. Regular monitoring of kidney function and for signs of infection is also essential.
What are some of the potential complications that can arise during pregnancy in women who have undergone a heart transplant?
Despite careful management, several potential complications can occur. These include acute or chronic rejection of the transplanted heart, graft dysfunction where the heart doesn't function optimally, and an increased susceptibility to infections due to the chronic immunosuppression.
Hmm.
Additionally, as we've discussed in other high-risk pregnancies, hypertensive disorders, including preeclampsia and gestational hypertension, are more common in this population.
It sounds like preeclampsia is a recurring concern. What is the reported incidence of hypertensive disorders and preeclampsia, specifically in pregnancies after a heart transplant?
Hypertensive disorders of pregnancy as a group have been reported to occur in approximately 26% of pregnancies in women post-heart transplant.
Wow, quite high.
Yeah. More specifically, preeclampsia has been reported in around 18% of these pregnancies. These rates are significantly higher than in the general pregnant population.
And what about the babies born to mothers who have had a heart transplant? Are there any specific risks or considerations for them after birth?
Yes, preterm deliveries are quite common, with more than half resulting in the baby being born before 37 weeks.
Okay.
Additionally, because the immunosuppressant medications the mother takes can cross the placenta, there's a potential for these to have effects on the neonate. Babies born to mothers post-transplant require careful monitoring after birth to assess for any potential effects like low birth weight, prematurity complications, and potential effects on their own immune systems.
That's a lot of complex factors. It really underscores the critical need for highly specialized, coordinated medical care. Now, let's shift our focus to a different area: ischemic heart disease during pregnancy. We don't typically think of this as common, but I understand it can happen.
You're right. While historically ischemic heart disease reduced blood flow to the heart muscle was less common during pregnancy compared to other cardiac conditions, it is becoming increasingly important to understand. Pregnancy itself creates a number of physiological changes that can actually increase a woman's risk for cardiac ischemic events.
Such as,
Mhm.
what specific changes during pregnancy make a woman more vulnerable?
Several factors contribute. Firstly, there's often a pregnancy-associated increase in LDL cholesterol, the bad cholesterol.
Right.
Secondly, pregnancy is a hypercoagulable state, meaning blood clots form more easily. Inflammatory changes, especially with preeclampsia or infections, can also play a role. Additionally, hormonal changes might subtly affect artery wall strength. increased vascular reactivity, blood vessels prone to spasm, and even the use of certain medications like prostaglandin analogs for postpartum hemorrhage can potentially contribute in susceptible individuals.
So while it might have been less common historically, you mentioned it's expected to become more prevalent. Why is that?
The expectation of a future increase is primarily driven by two main trends: a rising average maternal age as more women delay childbearing,
Yeah.
and the increasing overall prevalence of traditional atherosclerotic risk factors
Yeah.
like chronic high blood pressure, high cholesterol, and diabetes among women of reproductive age. As these become more common in pregnant women, we're likely to see more ischemic heart disease during pregnancy.
What is the estimated incidence of myocardial infarction, a heart attack, occurring during pregnancy? Is it still considered rare?
While not the most common complication, the incidence of MI during pregnancy is estimated at about 3 cases per 100,000 pregnancies. While that might seem low, it's a very serious event when it happens, associated with a significant case fatality rate of around 5%.
Wow. And what are the primary causes of these heart attacks during pregnancy? Are they the same as in the general population?
The causes can be somewhat different. While coronary atherosclerotic disease typical plaque buildup accounts for a significant portion, maybe up to 40%.
Yeah.
An often surprising finding is that spontaneous coronary artery dissection, or SCAD, has been identified as a leading cause responsible for up to 43% of cases in some studies.
That's huge.
Yeah. Other causes include intracoronary thrombus, a blood clot forming in the artery, up to 17%, and coronary artery spasm, around 2%.
When, during the course of pregnancy or postpartum, are these heart attacks most likely to occur? Is there a particular time of heightened risk?
Interestingly, the majority tend to happen in the third trimester or in the postpartum period, particularly the first few weeks after delivery.
Hmm.
This timing really underscores the significant cardiovascular strain during these later stages and immediately following childbirth.
How is a heart attack actually diagnosed in a pregnant woman? Is the approach similar? Are there challenges?
The diagnosis is generally similar to non-pregnant patients. It relies on the same tools: ECG, cardiac enzyme blood tests, and imaging like echocardiography.
Right.
However, it's important to know that typical symptoms like chest pain might sometimes be less clear-cut or attributed to common pregnancy issues like heartburn or reflux. This means clinicians need a high index of suspicion.
And what about the specific type of heart attack during pregnancy? Is one type more common?
Yes, ST elevation myocardial infarction, or STEMI, the more severe type with complete blockage, is more common during pregnancy compared to non-ST elevation MI and a STEMI.
Okay.
Additionally, studies show up to 2/3 of MIs during pregnancy involve the anterior wall of the left ventricle, the main pumping chamber.
Let's delve a bit deeper into spontaneous coronary artery dissection, or SCAD, since it seems surprisingly common. For listeners, what exactly is SCAD?
Okay, S. It's a condition where a sudden tear occurs within the wall of a coronary artery. This tear can lead to an intramural hematoma, basically, trapped blood within the artery wall layers.
Right.
This hematoma can then narrow the true lumen, the inside space, significantly reducing or blocking blood flow to the heart muscle. It's spontaneous because it typically happens without trauma or obvious plaque rupture.
Are there different ways that SCAD can manifest or be classified?
Yes, SCAD is generally classified into 3 main types based on its appearance during coronary angiography, the imaging procedure.
Mm-hmm.
Type 1 has a classic look with multiple lumens and dye staining the wall, seen in less than a third of cases. Type 2 is most common, showing a diffuse, smooth narrowing. Type 3 can sometimes mimic typical atherosclerosis or spasm, often needing additional intravascular imaging like IVUS or OCT for diagnosis.
So if a doctor suspects SCAD in a pregnant woman having a heart attack, what's the immediate course of action?
Urgent coronary angiography should be performed in any pregnant woman suspected of having SCAD, and also those presenting with STEMI. Because, as we said, SCAD is a frequent cause of STEMI in this population. Getting a clear picture is essential for diagnosis and treatment.
That makes sense. Now, I recall reading a note of caution against using thrombolysis, clot-busting drugs for STEMI in pregnant women. Why is that?
Because SCAD is such a relatively common cause of STEMI during pregnancy, thrombolysis isn't usually the preferred initial strategy.
Right.
While the drugs themselves don't cross the placenta, their use significantly increases the risk of maternal bleeding, including placental bleeding, which is dangerous for both mother and baby.
Yeah.
Plus, in SCAD, the problem is the tear and hematoma, not usually a traditional clot. So thrombolytics wouldn't address the underlying issue and could cause serious bleeding without benefit.
Are there any specific risks associated with the diagnostic procedures, like angiography in pregnant women with SCAD?
Yes, there is a slightly higher risk of iatrogenic coronary artery dissection, meaning caused by the procedure itself, by the catheter in patients with SCAD compared to standard angiography.
Why?
It's thought the underlying weakness in the artery walls predisposing to SCAD might also make them more susceptible to injury during catheter manipulation. The risk is estimated around 3%.
Hmm.
Also, there's some evidence suggesting the risk might be slightly higher with the radial approach, wrist artery, compared to the femoral approach, groin artery. So the femoral approach might be preferred by experienced operators in pregnant patients with suspected SCAD.
It sounds like the team needs to be extra careful and experienced.
Yeah.
Are there specific technical recommendations to minimize the risk of causing or worsening a dissection during angiography?
Yes, several technical recommendations exist. These include using smaller catheters, avoiding aggressive catheter manipulation, using gentle contrast dye injections, and minimizing catheter passes. The goal is to get the diagnosis while being as gentle as possible to potentially fragile arteries.
Given all these complexities, it seems like the experience and specialization of the medical center really matter. Where should pregnant women with suspected SCAD or other acute coronary syndromes ideally be treated?
Cardiac catheterization and any coronary interventions in pregnant women should ideally be done by experienced interventional cardiologists at specialized tertiary care centers with high volume in both complex cardiac conditions and pregnancy.
Right.
For a pregnant patient with NSTEMI or other acute coronary syndrome where things are more stable, angiography is reasonable but doesn't necessarily need to be an immediate emergency like with STEMI. Timing can be more considered based on the clinical situation.
That gives us a really important and detailed understanding of ischemic heart disease and SCAD during pregnancy. Let's now briefly summarize some key takeaways regarding IHD in pregnancy.
Okay. Firstly, it's important to reiterate that while women with pre-existing coronary artery disease or prior MI are currently a small proportion of pregnant women with heart disease, they're at significant risk.
Mhm.
A systematic review found ischemic events in a notable 9% of pregnancies in this group, with a 2% maternal mortality rate. Alarmingly, only about 21% of these pregnancies were reported as uncomplicated.
Wow, really highlights the risk. So, for women with known CAD considering pregnancy, what's the recommended approach pre-pregnancy?
Prior to pregnancy, women with known CAD should undergo thorough evaluation and treatment of any correctable lesions associated with ischemia. For those with significant coronary stenosis that can't be further treated with interventions or surgery, avoiding pregnancy should be seriously considered and discussed due to the high potential risks.
And what about recommendations for care during pregnancy and delivery for women with pre-existing IHD or those who experience an MI or SCAD during pregnancy?
Similar to patients with a SCAD or acute MI during pregnancy, women with pre-existing CAD who become pregnant should receive comprehensive, coordinated care from a dedicated pregnancy heart team. They should plan to deliver at a medical center equipped for coronary revascularization and advanced cardiac therapies, including intensive care if needed. This is crucial for managing potential complications.
Are there any medications commonly used for CAD that are generally considered safe to continue during pregnancy?
Yes, several are generally considered safe. These include low-dose aspirin, beta-1 selective beta blockers like metoprolol, nitrates for angina, and clopidogrel, an antiplatelet medication.
What about ACE inhibitors and statins, which are also common? Safe during pregnancy?
ACE inhibitors are generally not recommended during pregnancy due to potential fetal risks. However, they can typically be safely restarted postpartum if needed, and some are compatible with breastfeeding.
Okay.
Statins are also generally avoided during pregnancy due to theoretical concerns, but they can also be safely restarted postpartum for women needing them for cholesterol management and long-term risk reduction.
Okay, that gives us a really good overview of ischemic heart disease in pregnancy. Let's now move on to another important category, valvular heart disease, starting with rheumatic mitral stenosis.
Right. Rheumatic mitral stenosis, or MS, is the most common type of valvular heart disease encountered in pregnant women globally. It's a long-term complication from rheumatic fever that damages the mitral valve between the left atrium and ventricle.
How does pregnancy and its physiological changes typically affect women with mitral stenosis?
The normal changes during pregnancy, like increased stroke volume and heart rate, can significantly impact women with MS.
How so?
These changes elevate the pressure gradient across the narrowed valve and increase pressure in the left atrium. This can worsen symptoms like shortness of breath, significantly increasing the risk of pulmonary edema, fluid in the lungs, and atrial arrhythmias like AFib.
Hmm.
Additionally, the hypercoagulable state of pregnancy increases the risk of blood clots forming in the enlarged left atrium.
And how does the mother's mitral stenosis, in turn, affect the developing baby?
The impact on the fetus can be quite significant. Maternal MS is associated with increased rates of preterm birth, intrauterine growth restriction, IUGR, and unfortunately, even fetal death.
Why is that?
These adverse outcomes are largely due to the mother's heart's impaired ability to adequately increase cardiac output during pregnancy, leading to uteroplacental insufficiency, reduced oxygen and nutrient flow to the placenta and baby.
It sounds like the severity of the mitral stenosis would play a very important role in these complications.
Absolutely. The frequency and severity of complications generally correlate directly with the degree of valve narrowing. Plus, within each severity class, risk can be further elevated by pre-existing symptoms, left ventricular systolic dysfunction, prior heart failure, and pulmonary artery hypertension.
I noticed the definition of severe mitral stenosis has been updated. Can you tell us about that?
Yes, recent updated guidelines have refined the classification. A mitral valve area of 1.5 square centimeters, centimeter 2 or less, is now classified as severe or significant MS. This updated definition now includes the range of 1.1 to 1.5 centimeter 2, previously often classified as moderate. It reflects a better understanding of the risks associated with different degrees of narrowing.
And what about outcomes for pregnant women with MS in different parts of the world? Are there big differences based on access to health care?
Yes, unfortunately, there are significant disparities. In countries with high prevalence of rheumatic heart disease and limited access to specialized cardiac care, reported maternal mortality rates have been tragically high, sometimes up to 34%.
Wow.
This contrasts starkly with much lower rates in middle to high-income countries with better access to diagnosis, treatment, and management, highlighting the critical role of healthcare resources.
Given these risks, what are the current recommendations for managing rheumatic MS in women planning pregnancy or already pregnant?
Current guidelines strongly recommend that women with significant MS valve area at 1.5 centimeter 2 should ideally undergo percutaneous balloon mitral valvuloplasty, PBMV, a catheter procedure to widen the valve or surgical valve repair replacement before becoming pregnant if possible. This pre-pregnancy intervention aims to reduce their risk of heart failure and AFib during pregnancy. However, it might not be deemed necessary for all women, especially those with access to close specialty care, normal exercise tolerance, low clot risk, and no pulmonary hypertension.
What kind of ongoing monitoring is recommended for pregnant women known to have mitral stenosis?
Pregnant women with MS should be followed serially, minimally, at least once in the first trimester and again in the third when hemodynamic stress peaks.
Okay.
However, women with severe MS or symptoms will likely need much more frequent follow-up, often monthly or even more often, to closely monitor their status.
I understand pressure gradients across the valve change during pregnancy.
Yeah.
How is severity best assessed then?
Because flow and therefore the pressure gradient increase during pregnancy, the severity of MS is best and most consistently assessed by directly measuring the mitral valve area using echocardiography.
Ah, the area itself.
Exactly. The valve area provides a more reliable, less flow-dependent measure of the actual mechanical obstruction compared to just the gradient.
What role do medications play in managing MS during pregnancy? Are specific drugs preferred?
Beta-1 selective beta blockers are often a mainstay, especially for those with significant stenosis or symptoms like palpitations or rapid heart rate. They help control heart rate and improve symptoms.
Okay.
If a woman's functional class deteriorates, suggesting early heart failure, loop diuretics should be started for fluid overload, beta blocker doses might increase, or digoxin might be added for rate control. Activity restriction is also generally advised. Specific target heart rates aren't definitively established, though. It's usually individualized.
Atrial tachyarrhythmias, like AFib, seem frequent and potentially serious. How are they managed?
Yes, atrial tachyarrhythmias, particularly AFib, are a frequent cause of maternal heart failure, especially in the third trimester. Anticoagulation is strongly recommended for women who develop AFib, have a clot in the left atrium, or have a prior history of embolism. In women with significant MS in normal rhythm but higher clot risk, anticoagulation should also be considered if there's spontaneous echo contrast, sluggish blood flow, a large left atrium, 60 millinL M2, or a history of congestive heart failure.
And what about more invasive treatments like mitral valvuloplasty? Can that be done during pregnancy if needed?
Yes, PBMV can be performed during pregnancy in carefully selected cases. However, it's usually reserved for women who develop severe refractory symptoms or progressive heart failure, despite maximal medical therapy and hospitalization.
Okay.
The decision requires a very careful, multidisciplinary assessment of risks and benefits for both mother and fetus, as it has its own potential complications.
That gives us a very thorough understanding of rheumatic mitral stenosis. Let's now move on to discuss mitral regurgitation.
Okay, mitral regurgitation, or MR, is where the mitral valve leaks backward from the left ventricle to the left atrium. In general, isolated MR in pregnancy carries a lower risk of maternal and fetal mortality compared to mitral stenosis.
However, even though the risk might be lower, it can still pose problems, correct?
Yes, while overall risk might be lower, moderate to severe MR is still associated with heart failure in about 23% of pregnancies in women with rheumatic heart disease.
Right.
Furthermore, it's been identified as an independent predictor of maternal cardiac complications during pregnancy, regardless of the cause, so it still needs careful monitoring.
What kind of follow-up is recommended for pregnant women with moderate or severe MMR?
Patients with moderate or severe MR should undergo serial follow-up throughout the antepartum period, similar to MS patients. Regular monitoring allows tracking symptoms, assessing heart function via echo, and identifying early signs of worsening failure or complications.
Are there specific considerations when assessing MR severity during pregnancy? Can the physiological changes affect how it appears?
Yes, clinicians should be aware that the normal decrease in systemic vascular resistance after load in the second and third trimesters can sometimes lead to an underestimation of the true severity of MR on echo.
So,
The reduced afterload might result in less blood leaking backward at any given blood pressure. So interpreting echo findings needs to be done in the context of the woman's overall clinical presentation and symptoms.
what about immediately after delivery? Any special considerations for women with MR or MS?
It's often recommended that a single dose of intravenous loop diuretics be given within the first few hours postpartum in patients with moderate or severe MR or MS.
Why?
It's a proactive measure to help prevent redistribution edema, which can occur as the body adjusts fluid levels after birth and the increased blood volume starts to redistribute.
And what about the preferred delivery method for women with predominant mitral valve disease?
For patients with predominant mitral valve disease, stenosis, or regurgitation, vaginal delivery with epidural anesthesia is generally preferred, absent other obstetrical reasons for C-section.
Okay.
Cesarean delivery is typically reserved for patients with more severe cardiac disease, like NYHA class 3V heart failure symptoms or significant pulmonary hypertension despite medical therapy.
Finally, what about mitral valve prolapse, which is relatively common? Is that typically a concern during pregnancy?
Mitral valve prolapse, where the leaflets bulge into the left atrium, is generally considered low risk during pregnancy for most women who have it. Significant complications are uncommon unless there are specific associated issues, which unfortunately aren't detailed in our sources.
Okay, let's move on to another crucial valve,
Yeah.
the aortic valve, specifically aortic stenosis.
Right. Aortic stenosis, or AS, is a narrowing of the aortic valve controlling blood flow from the left ventricle to the aorta. In women of childbearing age, it's most often caused by a bicuspid aortic valve, 2 leaflets instead of 3. AS poses significant challenges during pregnancy because it limits the heart's ability to increase cardiac output and adapt to hemodynamic changes, increasing risk for heart failure, ischemia, and hypotension.
Are there different levels of severity that affect how pregnancy is tolerated?
Yes. Asymptomatic women with only mild AS typically tolerate pregnancy well. However, women with moderate or severe AS are at higher risk for heart failure, arrhythmias, and angina, chest pain. Although mortality risk with severe AS is relatively low in the current era with good care.
Okay.
For subvalvular AS, narrowing below the valve, a resting gradient 30 mm of Hg is generally considered significant.
How is risk assessed and managed in asymptomatic women with severe AS considering pregnancy?
Current guidelines recommend exercise testing for asymptomatic women with severe AS considering pregnancy to assess function capacity and heart response to stress.
Right.
Aortic valve replacement, AVR, surgical or percutaneous, is generally recommended for symptomatic AS or asymptomatic women with LV systolic dysfunction, EF 50%, or abnormal exercise test responses. While pre-pregnancy AVR has been suggested for severe asymptomatic AS, the decision should be individualized based on LV function and exercise testing.
What about the type of AVR considered especially for younger women wanting future pregnancies?
Anatomic suitability for a Ross procedure is an additional factor to consider in carefully selected younger patients.
What's that?
It's a complex surgery using the patient's own pulmonary valve to replace the aortic valve. Potential benefits include avoiding long-term anticoagulation needed with mechanical valves and potential for better durability and growth.
How should women with known AS be followed up during pregnancy? Any common medications?
Patients with AS require regular follow-up, similar to mitral lesions. Diuretics are used for heart failure symptoms. Beta blockers might help control heart rate and blood pressure.
Hmm.
The optimal delivery method isn't definitively established. However, C-section is often thought by clinicians to potentially reduce maternal stress and facilitate controlled hemodynamic monitoring if needed.
Are there interventions like valve procedures that can be done during pregnancy if a woman with AS develops significant problems?
Percutaneous balloon aortic valvuloplasty can be considered like a temporary measure for refractory symptoms in the antepartum period. AVR surgery during pregnancy or timed with C-section might be considered for life-threatening symptoms when percutaneous options aren't feasible. Transcatheter aortic valve replacement, TAVR, has also emerged as a potential option in highly selected, high-risk pregnant patients.
That covers aortic stenosis.
Yeah.
What about aortic regurgitation? How's that tolerated?
Aortic regurgitation, or AR, leakage back into the left ventricle, is generally better tolerated during pregnancy compared to AS.
But still potential issues.
Yes. One small study reported pulmonary edema in about 29% of pregnancies with severe AR. If functional status declines or heart failure symptoms develop, they usually respond to loop diuretics.
Now let's briefly touch on the pulmonary and tricuspid valves.
Yeah.
We don't hear as much about issues with these during pregnancy.
You're right. Most women with significant pulmonic stenosis, PS, would likely have had balloon valvuloplasty in childhood. The few reported cases of severe PS during pregnancy generally had favorable outcomes, with infrequent right heart failure. Severe pulmonic regurgitation, PRs, is also usually well tolerated, possibly due to reduced pulmonary vascular resistance during pregnancy. While right heart failure has been reported with severe PR, many cases involved underlying RV dysfunction from complex congenital lesions.
Mm.
Isolated tricuspid stenosis, TS, is quite rare, lacking systematic outcome data. Tricuspid regurgitation, TR, can actually increase during normal pregnancy due to physiological changes. Moderate TR isn't unusual. Women with isolated severe TR generally tolerate pregnancy well if the RV isn't the systemic ventricle, though data are absent.
Right.
In congenital heart disease patients, moderate severe TR was an independent predictor of complications in some studies, but not consistently replicated. Generally, right heart failure from right-sided valve lesions responds to loop diuretics, and interventions can often wait until after pregnancy.
That gives us a good overview of all the heart valves. Now let's move to a specific group, those with prosthetic heart valves and the critical management of anticoagulation.
Right. Women with prosthetic valves face unique risks, and thorough preconception counseling is essential to assess risk and discuss complications before planning pregnancy.
Are there big differences in risk between prosthetic valve types?
Yes, significant differences. Bioprosthetic valves from tissue generally carry lower pregnancy risks than mechanical valves,
Why?
primarily because they're less thrombogenic, less likely to cause clots, and don't typically require long-term anticoagulation like warfarin. Women with normally functioning bioprosthetics, good functional class, and normal LV function are generally low risk for maternal complications.
Okay.
But bioprosthetics can degenerate over time, so older valves might have abnormal function, stenosis regurgitation, increasing risk. Also, there's limited pregnancy experience with the Ross procedure.
What about pregnancy with mechanical heart valves? Sounds higher risk.
Pregnancy with mechanical valves is indeed associated with significant maternal and fetal risks. The most serious maternal complication is prosthetic valve thrombosis clot formation on the valve.
Which can be.
Potentially life-threatening. It can cause valve malfunction, stroke, systemic embolism, and even maternal mortality.
Are there specific factors influencing thrombosis risk in pregnant women with mechanical valves?
Yes. The type and intensity of anticoagulation matter. Warfarin generally provides better protection than heparin. The valve type also plays a role. Newer bileaflet valves are lower risk than older tilting disc ones. And valve position matters. Mitral valves carry higher risk than aortic.
So what are the anticoagulation options for pregnant women with mechanical valves, and what are the pros and cons for mother and baby?
3 main options. Warfarin, or other vitamin K antagonists, low molecular weight heparins, LMWH, and intravenous unfractionated heparin, direct oral anticoagulants, DOACs, are currently considered unsafe.
And no perfect option.
No, there's no single perfect anticoagulant equally safe and effective for both. Warfarin generally has the lowest maternal thrombosis and mortality risk, but UT readily crosses the placenta. It can cause warfarin embryopathy, birth defects, if used in the first trimester, weeks 6-12, and fetopathy later, affecting CNS, eyes. Embryopathy seems dose-dependent, lower rates at 5 milligrams daily.
Okay, what about heparin?
Heparin doesn't cross the placenta, so it's safer for the fetus regarding direct teratogenic effects. However, heparin, especially subcutaneous unfractionated heparin, is less effective at preventing valve thrombosis and has been linked to higher maternal thromboembolic events and mortality. LMWH is better than unfractionated heparin, but still may not be as effective as warfarin, especially for high-risk valves.
That sounds like a very delicate balancing act. Are there common strategies to minimize risks?
Yes. One common strategy is switching from warfarin to LMWH during the critical embryogenesis period, weeks 6-12, to prevent embryopathy.
Right.
After the first trimester, some might switch back to warfarin for the remainder, carefully managing dose. Another approach is using LMWH throughout pregnancy, but this needs very close, frequent monitoring of anti-ZASI levels, maybe weekly, monthly peaks, sometimes trough levels too. Given the complexity, managing anticoagulation requires close collaboration with a hematologist experienced in pregnancy and prosthetic valves. Subcutaneous unfractionated heparin is generally discouraged, except as a continuous IV infusion in hospital. Also, women on anticoagulants have increased postpartum hemorrhage risk. Both heparin and warfarin are considered safe for breastfeeding.
That really highlights the complexities. Clearly needs highly individualized, closely monitored care. Let's shift focus now to arrhythmias during pregnancy, starting with supraventricular tachycardia.
Okay. Supraventricular tachycardia, or SVT, is actually the most common arrhythmia in pregnant women. Interestingly, it typically presents in women with structurally normal hearts.
Can SVT present for the first time during pregnancy, or is it usually a recurrence?
It can certainly be new onset during pregnancy, or it can be a recurrence in women with prior episodes. Women with a history of SVT and underlying structural heart disease have a higher recurrence risk, maybe around 50%.
How is an acute episode of SVT typically managed in stable pregnant women?
Fortunately, most acute SVT episodes in hemodynamically stable women can be managed effectively. Initial treatment often involves vagal maneuvers, simple physical actions like bearing down or coughing forcefully.
Right.
If those don't work, the next step is often intravenous adenosine, which works very quickly to interrupt the abnormal pathway.
What if adenosine isn't an option or doesn't work? Other medications?
For contraindications or ineffectiveness, intravenous beta blockers like metoprolol or propranolol can be used. They slow the heart rate. Experience with other antiarrhythmics is more limited, usually reserved for highly symptomatic women not controlled by adenosine or beta blockers.
Okay, let's move on to atrial fibrillation and atrial flutter. How do these typically present and how are they managed in pregnant women?
Atrial fibrillation, AFib, and atrial flutter, AFL, are more complex rhythms, often occurring with underlying structural heart disease like mitral stenosis or congenital issues. Generally, the primary initial goal is rate control, controlling how fast the ventricles beat. Rhythm control, converting back to normal rhythm, is also considered but often secondary initially.
When would immediate conversion be necessary?
Pregnant women with acute AFib or AFL who are hemodynamically unstable, causing low blood pressure, severe chest pain, shortness of breath, require immediate electrical cardioversion to reset the rhythm quickly.
What about in more stable situations? How is the rapid rate managed?
In stable pregnant women with rapid rates from AFib-AFL, medications like intravenous beta blockers, metoprolol, esmolol, or digoxin can slow the rate and alleviate symptoms. Calcium channel blockers might be used cautiously, especially with LV dysfunction.
I know there's concern about blood clots before elective cardioversion in non-pregnant patients. Same concern during pregnancy.
Yes, absolutely. Just like non-pregnant patients, if AFib-AFL has lasted 48 hours or unknown duration, there's increased clot risk in the left atrium. So before elective cardioversion, electrical or drug, a transesophageal echo, TEE, is often needed to look for clots. If a clot is found, cardioversion might be delayed until after anticoagulation. Alternatively, if no TE, therapeutic anticoagulation for at least 3 weeks prior is typical.
If medications are used for pharmacologic conversion, Any specific considerations?
Pharmacologic cardioversion needs to be highly individualized. The choice of drug depends on underlying heart disease, LV function, and the clinical situation. Some drugs common outside pregnancy might pose fetal risks, so benefits and risks must be weighed carefully.
I also saw a note about Wolff-Parkinson-White syndrome with AFib. What's the concern there?
Managing AFib, AFFL in pregnant patients with WPW requires extra caution. WPW involves an extra electrical pathway.
Right.
Certain common AFib drugs, beta blockers, some calcium channel blockers, digoxin, can paradoxically worsen the arrhythmia by increasing conduction over this extra pathway, leading to dangerously fast ventricular rates.
So what's used instead?
In pregnant women with WPW and AFib-AFL, drugs that primarily slow or block the accessory pathway, like procainamide or flecainide, are generally preferred.
And what about clot risk in pregnant women with AFib-AFL? Is anticoagulation needed? Preferred agents?
Thromboembolism prophylaxis, blood thinners, should be considered for all pregnant women with AFib-AFL, especially those with structural heart disease, prior embolism, or elevated CHD2 score. Warfarin carries risk in the first trimester, so low molecular weight heparin, LMWH, is often used during pregnancy. Direct oral anticoagulants, DOACs, are currently not recommended due to lack of safety data.
Okay, that covers AFib and flutter. Now let's discuss the more serious ventricular arrhythmias. Ventricular tachycardia and ventricular fibrillation.
Right. Ventricular tachycardia, VTAC or VT, and ventricular fibrillation, VFib, are potentially life-threatening rhythms, fortunately relatively rare during pregnancy. When they occur, VT can be idiopathic, no clear cause, or associated with underlying conditions like cardiomyopathies, valve disease, congenital heart disease, long QT syndrome, LQTS, electrolyte imbalances, or severe hypertensive crises.
How are acute episodes treated if they occur during pregnancy? Similar to non-pregnant.
Yes, acute unstable VT or VF in pregnant women needs the same immediate aggressive approach. Immediate electrical cardioversion or defibrillation to terminate the dangerous rhythm. For pharmacologic options in recurrent or stable VT, IV procainamide, amiodarone, and lidocaine can be considered.
What about more stable or less immediately life-threatening forms of VT?
Idiopathic VT, often from the right ventricular outflow tract, is usually monomorphic and well tolerated. It can often be effectively treated with beta blockers or the calcium channel blocker verapamil.
I recall reading VT risk might be higher with long QT syndrome, specifically postpartum. Why and how is it managed?
Yes, women with LQTS, especially the LQT2 mutation, have increased risk of VT and other arrhythmias postpartum. Hormonal shifts and electrolyte changes after delivery might contribute.
Right.
Beta blockers are effective prevention. Current recommendations are that all pregnant women with LQTS should be treated with beta blockers throughout pregnancy and continued postpartum to reduce this heightened risk.
What about VT with underlying structural heart disease? Different management.
VT with structural heart disease is generally more complex. Management is highly individualized based on the heart condition, VT characteristics, and clinical status. Antiarrhythmics may be used. In some cases, invasive interventions like catheter ablation or an ICD might be considered, even during pregnancy in selected high-risk patients.
Any specific drug concerns?
Amiodarone is effective but can affect fetal thyroid function, so its use should generally be reserved for recurrent VT, not controlled by safer drugs. Catheter ablation is an option for drug-refractory VT, but should be done at experienced centers.
Okay, that covers major arrhythmias. Let's move to congenital cardiac shunts and their implications for pregnancy.
Women with successful closure of isolated left-to-right shunts, like ASDs or VSDs, are generally considered low risk during pregnancy. The closure eliminates the abnormal flow.
And if there are no other issues, where can they typically deliver?
In the absence of other risk factors like arrhythmias, post-closure events, ventricular dysfunction, or pulmonary hypertension, women with successfully repaired isolated shunts can usually plan to deliver locally without needing specialized cardiac monitoring.
What about women with unoperated atrial septal defects, ASDs, who get pregnant?
Women with unoperated ASDs generally tolerate pregnancy quite well. Rates of significant arrhythmias, right heart failure, or thromboembolism are typically low, especially if the ASD is small.
And unoperated VSDs or patent ductus arteriosus, PDAs, in women of childbearing age. Major concern.
In women of childbearing age, most unoperated VSDs or PDAs are likely small or restrictive. Large, uncorrected shunts usually cause significant pulmonary hypertension earlier. So women with small VSDs or PDAs and no other risk factors generally don't need extra cardiac precautions during pregnancy or
We
delivery.
saw a recommendation about using air filters and IV lines for certain shunts. Why?
For women with unrepaired ASD-VSD, repaired ones with residual shunt or a patent form in OVIL, BFO, there's a potential risk of paradoxical right-to-left shunt,
Meaning?
meaning clots or air bubbles entering the venous system could cross to the left side via the shunt and travel to the body, potentially causing stroke. Using air particulate filters on IV lines during labor delivery is a precaution to reduce this risk.
Let's talk about bicuspid aortic valve, BAV, common congenital condition. Implications for pregnancy.
BAV is very common in women of childbearing age and a known cause of AS and AR, as we discussed. Importantly, BAV is also frequently associated with dilatation, enlargement of the ascending aorta, and aortic coarctation narrowing. While aortic dissection, tear, has been reported in pregnant women with BAV and aortopathy, the overall risk is generally lower than with Marfan syndrome.
What about aortic coarctation itself during pregnancy?
Yeah.
Main concerns.
Significant aortic coarctation can impede blood flow to the lower body, potentially impacting placental circulation and increasing risk of IUGR and premature labor.
Okay.
Upper body hypertension, common with coarctation, and coexisting aortic valve disease add risk. Maternal mortality is rare now with good management, but overly aggressive treatment of upper body HTN could cause hypotension distally, harming the fetus.
Right.
Even after successful coarctation repair, abnormal aortic compliance, stiffness, can increase risk of gestational hypertension.
How is coarctation monitored and managed during pregnancy?
An elevated gradient in the descending aorta might be seen on Doppler. Could be increased flow, abnormal compliance, hypoplasia, or true coarctation. A diastolic tail on Doppler strongly suggests true coarctation.
Okay.
Women with unrepaired or residual coarctation are at risk for aortic complications like dissection, often offered empiric beta blocker therapy. Percutaneous intervention is best postponed until after pregnancy if possible.
Let's move to left-sided valvular regurgitation from acquired heart disease. How is that managed?
Left-sided systemic AV regurgitation, like acquired MR or AR, is managed similarly to non-pregnant individuals, focusing on treating heart failure symptoms. While isolated mild-moderate regurgitation might be well tolerated, concomitant systemic ventricular systolic dysfunction significantly increases risk. The weakened heart adapts poorly to pregnancy's volume load plus the regurgitant flow.
So,
Patients with moderate or severe regurgitation need close serial follow-up. Consider postpartum 5V lift diuretics to reduce pulmonary edema risk.
what about congenitally corrected transposition of the great arteries, CCTGA? Rare and complex implications.
CCTGA is complex. The right ventricle acts as the systemic ventricle and is often weaker. Significant systemic AV regurgitation, usually tricuspid, is also common. Importantly, the regurgitation can sometimes mask the underlying systolic dysfunction. Complications like heart failure, endocarditis, stroke, MI have been reported. Pregnancy should generally be discouraged in patients with poor functional class, severe systemic ventricular dysfunction, or severe systemic AV regurgitation due to high risks.
Let's discuss cyanotic congenital heart lesions in pregnancy. Main concerns and management.
Cardiac causes of cyanosis, low oxygen, in pregnant women without pulmonary hypertension include large shunts, systemic to pulmonary venous collaterals, or reduced pulmonary blood flow. Maternal cardiovascular complications occur in about 30% of pregnancies related to maternal oxygen levels, low live birth rate if O2 sat 85%.
So management.
Supplemental oxygen and activity restriction are recommended. Thromboembolic prophylaxis is considered but must balance against bleeding risk, as cyanosis is linked to both abnormal clotting and bleeding, increasing postpartum hemorrhage risk.
Okay.
Due to high complexity, care by a specialized pregnancy heart team and delivery at a tertiary center are strongly recommended.
Let's move on to pulmonary arterial hypertension, PAH. I understand this carries exceptionally high risks.
PAH from any cause is indeed associated with very high maternal and fetal risks. Defined as mean pulmonary arterial pressure, 25 millimeter Hg, higher pressure means higher risk.
Why is this so risky?
Maternal cardiac decompensation frequently occurs due to RV volume load, increased flow in high-resistance pulmonary vessels, changes in shunting causing desaturation, and pregnancy's prothrombotic effects. Labor delivery stresses, anesthesia, fluids, volume shifts worsen it.
How high are the risks?
Reviews report alarmingly high maternal mortality rates, 17–33% depending on cause. Deaths are often from right heart failure, sudden death, PAH crisis, PE, often within the first month postpartum.
Wow.
Despite improvements with vasodilator therapy, pregnancy is generally discouraged due to this high mortality risk. Reliable contraception is essential. Risks are high even if PAH is secondary to left heart disease. Pregnant women with PAH also have increased risks of eclampsia, preterm delivery, fetal death.
Given these very high risks, how is PAH managed in women who become pregnant despite them?
Termination often remains the safest option for the mother. For those continuing, very close specialized antenatal follow-up is needed. Frequent visits, echoes, BNP levels.
What about medications?
Many PAH meds like bosentan and endothelin receptor antagonists are teratogenic and must stop before pregnancy. Others like calcium channel blockers, PDE5 inhibitors, sildenafil, prostacyclins have been used, but safety efficacy aren't fully established.
Mm.
Close fluid monitoring is crucial throughout pregnancy and postpartum to prevent right heart failure. Joint care by pregnancy heart and PAH teams is vital. Delivery must be at a tertiary center with postpartum ICU monitoring, careful diuresis. Vaginal delivery might be considered if stable, with early epidural and assisted second stage. Extended postpartum monitoring is recommended.
Let's move on to Marfan syndrome and other inherited aortopathies, primary concerns for pregnant women.
Women with Marfan, Loeys-Dietz, vascular Ehlers-Danlos, Turner syndromes, or BAV with aortopathy have significantly increased risk of aortic dilatation and dissection during pregnancy, due to increased cardiac output volume plus pregnancy-related changes in the aorta structure. Dissection has been reported in all these. Highest risk is third trimester or early postpartum.
Focusing on Marfan, what are the estimated risks of aortic dissection rupture?
Incidence during pregnancy postpartum is about 8 times higher than non-pregnant Marfan women. Overall risk is 3%, but varies, lower, 1%. If aortic root 40 millimeters increases significantly, 10% plus, if 40 millimeter rapid dilation or prior dissection repair.
Right.
Prior aortic root replacement doesn't prevent distal dissection. Dissection can occur even in an aorta appearing normal size on imaging.
That's a sobering reminder. Now let's shift to a practical topic. Contraceptive options for women with cardiovascular disease.
Choosing the right contraception is very important, as some hormonal methods have side effects contraindicated in certain cardiac conditions. Options include barrier, hormonal, estrogen-containing progestin only, IUDs, permanent sterilization. Each has benefits, risks, effectiveness to consider with the cardiac condition.
General guidelines and considerations.
Barrier methods, condoms are safe, no hormonal thrombotic risk, but higher failure rates make them unsuitable if pregnancy poses high risk.
Okay.
Estrogen-containing contraceptives, pills, patch, ring, are effective but increase clot risk. Generally not recommended for high-risk conditions like mechanical valves, Fontans, severe LV dysfunction, CAD, history of thromboembolism.
Huh.
Progestin-only contraceptives, pills, injection implant, don't increase thrombosis risk like estrogen, safer for some, but can cause fluid retention, some have higher failure rates, maybe not ideal if pregnancy is prohibitive.
What about IUDs?
IUDs, copper, hormonal, are highly effective, long-acting, but insertion carries small risk of complications like profound vagal reaction, sudden drop heart rate BP, dangerous for severe PAH or Fontan. Insertion in monitored setting advised for these high-risk conditions.
And permanent options.
Permanent methods, tubal ligation, vasectomy, should be considered when pregnancy is contraindicated. Also, women with severe heart disease may have limited life expectancy, a relevant factor in planning.
That's comprehensive. Now, I noticed a proposed algorithm for diagnosing pulmonary embolism, PE, during pregnancy. Key steps.
Yes, the algorithm exists, but guidelines are limited, often based on lower evidence. It starts with assessing clinical probability based on symptom sign risk factors.
Risk factors.
Thrombophilus, older age, obesity, prior VTE, immobility, certain medical conditions. If PE likely or intermediate high probability, imaging, usually CT pulmonary angiogram, CTPA, is next.
What about D-dimer?
D-dimer testing might help rule out PE in low probability women, but levels are often elevated in normal pregnancy, so a higher cutoff might be needed. Given radiation concerns with CTPA, ventilation perfusion VQ scan is an alternative sometimes. Consider alternative diagnoses if PE ruled out. Given hemorrhage risk with systemic thrombolytics, especially postpartum, catheter-based thrombolysis might be alternative for massive PE. In stable PE patients, LMWH is generally preferred anticoagulant over unfractionated heparin.
The source material also briefly mentions post-delivery follow-up and late cardiovascular risk after pregnancy complications. Key considerations.
It acknowledges the importance but doesn't detail it. However, it's known women with hypertensive disorders, GDM, PPCM, other events during pregnancy have increased long-term risk of chronic HTN, IHD, heart failure, stroke.
So follow-up is key.
Yes, ongoing follow-up with primary care cardiologists is essential. Monitoring BP, cholesterol, sugar, lifestyle counseling, diet, exercise, smoking helps mitigate long-term risks. Research continues on understanding these links and risk reduction.
Finally, the source material references AHA scientific statement and 2018 ESC guidelines on CVD during pregnancy. Significance.
Yes, the AHA statement and ESC guidelines are comprehensive expert consensus documents. They synthesize evidence and offer practical guidance for clinicians managing various cardiovascular conditions during pregnancy. They include new revised recommendations based on latest research and are invaluable resources for healthcare professionals.
Good to know such resources exist. Finally, let's touch upon the overall conclusions from our discussion today.
Our deep dive clearly highlights that cardiovascular disease is a significant, increasingly recognized primary cause of maternal mortality. Factors like advancing maternal age and rising prevalence of pre-existing conditions, rheumatic, congenital, contribute to concerning trends.
Oh, what's crucial?
Comprehensive preconception counseling and early ongoing involvement of a multidisciplinary cardio-obstetrics team are absolutely crucial for thorough risk assessment. In high-risk pregnancies, this team's expertise and coordinated care are essential to implement optimal strategies to prevent maternal morbidity and mortality throughout pregnancy and the critical postpartum period.
Managing heart health during pregnancy is clearly complex, requiring a highly individualized approach tailored to each woman's condition and circumstances. Expert medical care and seamless collaboration of multidisciplinary teams are paramount for the best outcomes for both mother and baby. This deep dive aimed to give you a comprehensive overview of the critical considerations from our sources, offering valuable insights into this vital area of women's health. Considering the intricate interplay between the cardiovascular system and pregnancy, what further questions does this raise for you about the future of cardiac care for women, both during and beyond their reproductive years? We encourage you to keep exploring these important topics and always consult qualified healthcare professionals for personalized guidance.